This conference will now be recorded.
All right, so we'll cover Chapter 9, Patient Assessment, and then we'll do Airway Management, Chapter 10 next. The only thing you're not going to get out of airway management is going to be the hands-on portion. That is all coming towards the end of the program. We do all skills labs for the last 4 classes we do that are in person. All right, there'll be a couple lectures in the beginning, and then it's all skills, hands-on stuff, so it preps you and gets you ready for the national exam. All right, so that's how we're going to work that. Now, during your ride time, ask them about airway management. Have them show you the king tubes and things like that we're going to be utilizing. We'll cover them in class as well, but we're not going to be doing a lot of hands-on stuff until the end. We hit all the practical stations. You guys will be very proficient with this by the end. All right, so again, we're going to cover the National EMS Education Standard Competencies. So the standard competencies are set forth by the DOT, saying this is going to be the curriculum that you're going to utilize back in the 1970s when all this stuff came about. So they put these standard competencies in place, and obviously throughout time they've updated it and made them better for us to be utilized for the EMT level. So this applies scene information and patient assessment as well for scene size up, primary and secondary assessment, patient history and reassessment, and the guide to emergency management.
Here's what I found.
I put my phone on vibrate so it doesn't go off on you guys. We're going to talk about scene size up and scene safety. You're going to hear scene safety BSI a lot. You should be saying that in your sleep. Anytime you walk up to a situation, it's scene safety first. Make sure you have BSI, gloves, and nowadays mask, whatever you're going to need for that situation. Okay, and that's also one of those things in their National Registry skill sheets that you're going to see. Is scene safety BSI is a critical skill, and if you don't say it, you fail the station. Not just for me, but also for the National Registry. So scene safety BSI, very important. Memorize it. Every time you walk through a door before you go to bed at night, you say scene safety BSI before you hop in bed. Your civic other may look at you funny and say, huh, what's going on here? But scene safety BSI. And don't be afraid to practice your assessments on your significant others as well, appropriately, professionally, right? But that's how you learn. Take your skill sheet, have them hold it in front of it. They hold it, and then basically read it off and just assess. You've got to practice at home on clinical time, in classes. Just practice, practice, practice. Memorize these sheets. So scene management impacts the environment of patient care, addressing hazards, violence. When you walk in, your scene assessment starts from the time you get dispatched, because they're going to give you a bunch of information, tell you what level it's going to be, whether it be alpha to omega level. They're going to tell you where the patient potentially could be located at the 2nd floor, 1st floor. It all depends on how much information dispatch gets from the caller. They're going to give you info. So if you're responding to Water Village Road in Ospey Corner, for example, and they say 93 Water Village Road, I'm like, oh, that's the nursing home, right? So I know to expect staff meeting us at the front door, us going through a COVID screen before we go in, going upstairs, 2nd floor, take the elevator. I know what to expect. You may have the frequent flyers. I call them frequent flyer miles because you go there all the time to the homes. And you see them. You know what home you're going to walk into. But you need to be observant for when you pull up to the scene. How many cars are in the driveway? What kind of living conditions are they that you see? How many steps are we going to be walking up going into the house? Do I need to bring a stair chair with me right off the bat? Is it a chest pain? We never walk chest pains. We never walk shortness of breath. Because all it does is exacerbate the condition and make it worse. So we have to stair chair them out. What are we going to bring with us on every call? What is our go-to equipment? So for us here, it's written in policy. You will bring a first in bag, oxygen bag, and a cardiac monitor at every call. Because the last thing you want to do is walk into a home and all of a sudden, oh crap, I didn't need my monitor, the patient's in cardiac arrest. We got called for a fall. Yeah, the guy fell, and there was no update that he wasn't breathing and there's no pulse. So the last thing you want is to be caught in that situation. Oh, sorry, I got to run back outside to get my monitor. So stuff goes in. As you're walking in, what does the conditions look like? Do you notice any weapons? We are in New Hampshire. People have weapons in their homes. right? Doesn't matter. Me and same thing, right? I'm sure you've been to medical calls before. You've seen them, right? People have guns in the corner. They're not going to hurt you with them, but what if they're altered? What if you go for an altered mental stat? What if they're a diabetic and their sugars are low and they don't know where they are, what's going on? They grab a gun and shoot you, and So again, know where things are, secure the weapons. If you have an extra, I'm not saying take them and hide them on the patient, but if you have law enforcement, they can secure a weapon. You can park an EMT or a driver, in some cases in Maine where we have driver operators, and say, stand over there by the corner. You're going to block that weapon so I don't get shot, right? So pay attention to your surrounding, what's going on. Are they a hoarder house? And if they are, and we've seen those before, what is it going to take to get the patient out? Are we going to need to call for specialized equipment? Do we need more manpower to get a patient out? What if you get to the second floor, and this always happens, your 500-pound patients are always on the second floor in bed. You guys laugh about it now until you show up to your first call and be like, damn it. All right? So there's other methods of getting patients out of these homes. You just got to know what resources that you have available to you. So here at Action, we have a hover jack system that can carry heavier patients down flights of stairs. Literally, it takes a patient from the ground with no lifting and inflates in chambers to be about this high. And it slides. It has like a Teflon bottom. So it slides across concrete, grass, stairs, and it doesn't pop. Pretty neat stuff, right? Right. And it hooks like a harness and it zips over the top of it like a blanket, and you just down the stairs and you can get the patient outdoors. It takes minimal manpower to move it. So do you have those availability options in your area? We do here. Again, hazards, violence. Look around. What do you have? Where are they located? How many people are in the home? Look around for needles, because people do use drugs, so pay attention. When you're kneeling down in a home, the last thing you want is to go down in a hypodermic needle on your kneecap. Animals, snakes, alligators. But yeah, just be careful of people's pets. Oh boy. So toss it and run. So keeping that kind of stuff in mind, that's your seeing size up. And seeing size up and seeing safety doesn't stop. You could have a perfectly calm, cool, and collected patient turn on you on a dime, and next thing you know, they're very combative, hostile, verbal. And let me tell you, if your feelings get hurt easily, you got to change that, because you are going to be called every name you can think of, and ones you probably even know existed. Because you're going to have patients that just are complete a-holes that just want to try to verbally destroy you. And you can't let that get to you. You can't, right? Because you know who you are and what you do, right? We have places around here, we go to detox centers and everything else. You think they're going to be very polite? Some are not, right? You know your areas, right? So Berlin area. What two facilities do you guys have in Berlin? State prison and federal prison. Yep. So kind of keep that stuff in mind. They're not going to be nice, and some of them have incarceritis, and they just want to find a way to fake a symptom to get out and get to a hospital to get out of jail for a little bit. We get that a lot over at the county jail here. Please do not put down incarceritis in your own reports. Okay, it's not a diagnosis, right? But people do that kind of stuff, and they're not very polite. They're not. You're going to have those patients that are out there. They're going to treat you like absolute crap. But do your job. Don't get angry with them. Calm, cool, collective. Because once they feel like they've got a hold of you, they're not going to stop. You got to have the upper hand. So, and if you think there's a chance of violence, it's not abandonment if you need to leave for your safety. Walk away, right? Always keep your back towards an exit. Never put yourself in a situation where the patient is blocking an exit from you. That puts you in a bad situation. Need for additional or specialized resources. Again, if you need something, call for it. But know who you're calling, what you're calling for. Know your resources in your area. Standard precautions, masks, were never a standard precaution. Now they are, and I think they will be for a very long time. Even when things clear up and we're getting vaccines every year for this, like the flu, I think masks are not going to go away. At least in the EMS setting. Like now we're fine, but in the EMS setting on a call, I can't believe I didn't get more sick than what I am, more sick before, for 20 plus years doing this job, never wearing a mask. Even patients that had respiratory symptoms, we never wore a mask. Unless they had tuberculosis or other airborne disease, we never wore an N95. Now we walk in for a simple toe pain and we're wearing a mask. And one thing I've noticed, our employees are not getting as sick as they used to. It's amazing. So standard precautions nowadays: gloves, eye protection. They want you to wear now on every call, right? And glasses are not really considered eye protection. They don't have the shields on the side. So what are you guys doing over in Socopy? No. Yeah. Yep. But surgical mask on every call, right? So you guys are protecting. Wait till you deliver your first baby. We'll talk about protection. No, safety glasses are fine. Yeah. It's really to protect any kind of splash if someone coughs in your face. Or if someone decides to spit in your face, which will happen at some time in your career in EMS. Someone will try to spit in your face, and you're going to want to knock them right out, and you can't. As tempting as it may be, you can't do that. We got to walk away. Well, then it's implied consent. Multiple patient situations where you have more than one patient that's in front of you. And we'll get more into that later on when we talk about mass casualty incident. And everybody thinks of the word MCI, right? It's bad. It's 400 people. An MCI, by definition, is more than what your resources can handle at that time. You could have a motor vehicle crash with one ambulance, 5 patients, 4 critical. That's an MCI. Because more than what your resources you currently have available to be able to treat the casualties you have in front of you. And the goal of MCI is to take resources and casualties and come to an even ground, if not better. And that's our goal for MCI management. And we'll get into that like towards the end of the program. We'll talk about MCI management and things like that. Correct. Number of resources. And our goal is to take resources and patients and put them on a scale so everything's all the same. And until we have met that scale, we're not at a non-MCI incident. We've got to meet that even playing ground. All right. So the primary assessment for all patient situations, any patient you come in contact with, is level of consciousness. Are they alert and oriented? How do we do that? We ask them 4 questions, right? Person, place, time, event. If they can answer, I usually ask month, day, year, president, usually the president one. That's a dangerous question to ask nowadays. Whether it be Biden, Trump, doesn't matter, Bernie Sanders, I don't care. Someone doesn't like somebody and they tell you, oh, that guy. And that's being polite of some of the things I've heard about the president. But if they know who it is, now they tell you that it's Jefferson, that it's August 22nd, 1922, they're not alert and oriented. So you got to ask those questions. You got to determine level of competency. Because if they cannot make appropriate decisions, they're not allowed to have decision-making capacity. Therefore, it becomes implied consent to the patient. You have to treat them. And they have to be transported because they're not in right sound mind to make a patient refusal. Okay? So level of consciousness, right? As we're doing that, we're also doing a Glasgow Coma scale, which is eye, verbal, and motor function movement. Right? We'll get in that more. But that also adds from 3 being the worst to 15 being the best. Those are the scale numbers. Eye movement is 1 to 4. Verbal movement is 1 to 5. And then motor function is 1 to 6. And we'll break that down more later on. ABCs, airway, breathing, circulation. If I can sit here and have a conversation with Nick and say, Nick, how are you feeling today? Any chest pain or shortness of breath right now? No. and you went through a month, day, year president. He's talking to me. He's having a full conversation. I know that his airway's patent. He's talking. He's breathing fine because I'm looking at him right now. He's not tripoding. I don't see nasal flaring. I don't see any pursed lips. I don't see any accessory muscle use here. Okay. Speaking in full sentences. And he's not blue like a Smurf. So we're doing good. I know your breathing's good. And your skin color and temperature looks pretty good right now. I can tell you're not sweating. You're not diaphoretic. You're not pale, cool, or clammy. You have pink, warm, and dry skin. ABCs are normal. Airway, breathing, circulation. Now, that's a true assessment. I just had a conversation with him. We're talking, right? How long did that take? 15 seconds. I've already taken part of 2 parts of my assessment: level of consciousness, ABCs. Okay. The next part, level of consciousness, also is what they call an AVPU, AVPU scale. Okay. Now I know we're kind of going in depth on this. We're going to hit this again. AVPU is alert, completely alert to verbal. Okay. So if I talk to you, you're like, "Hey Nick, yeah, okay, that's alert to verbal." Alert to painful, Nick, can you hear me? And then I pinch you. You go, "Oh," and you pull away. Well, that's alert to painful stimuli. And if I get nothing, then he's unresponsive. Right? And one of the best tricks to check that is what they call a trapezius pinch. Everybody does sternum rubs, something else. Okay? You pinch up here, and you can drop somebody pretty quickly. That trapezius muscle, you pinch and you just like this, and you just turn like that. And they should move. Okay. And I'll teach you how to tell someone's faking stuff later on. Please do not drop their hand in their face. Okay, that's more damage. All right, but you can pinch them, and you can see if they do this to try to swat you away like that. Not responsive. Identify any life threats. Do I see any major bleeding? If blood is spurting out of an artery, it's a life threat, right? There's severed limb, life threat, tourniquets. Okay. Look for any like life-threatening situation, anything that will cause a patient to die within minutes. Okay, life threats. We're going to do assessment of the vital functions. We have to do vital signs. Vital signs include quite a bit: lung sounds, blood pressure, heart rate, respiratory rate, pulse oximetry, blood glucose, right? Pupillary response, huge, especially for strokes. Okay, so we're looking at all these different assessment techniques we have to utilize. Okay, then we're going to get also look at our general impression. Because when you walk into a room, who's been on medical calls already? A couple people have, right? When you walk in, you either know they're sick or they're not sick. That's our general impression: sick or not sick. If they look like crap, they probably are crap. Okay, they feel like crap. They're sick people. If they're having a conversation and they have 2-word dyspnea, they go, "Hi, my name is Kevin," like that. Okay, that's bad. That's a 2-word dyspnea. Patient's in severe respiratory distress. Patient is sick. We got to get going. We got to start getting treatments on this patient. If I have a conversation with Tandra and we're having a conversation sitting here back and forth, and she looks the way she is right now, she's not sick, right? So she's not sick. We have a little bit more time. So they used to use the term "stay and play" or "shit and get." Let's get out of here. Again, we have time to stay and play a little bit. We don't want to play too long. Okay, our max on scene time, our goal should be 20 minutes. Anything more than 20 minutes, we should be justifying why we're still there. We're gonna, so right. So that's gonna be based on vital signs, pulse oximetry, blood pressure. So if you have like a low blood pressure and a high heart rate, are they compensating for some type of shock? Are they septic? They have a high temperature. So you're gonna do your assessment, your vital signs. That's when you make the determination we need to go. Now, if you walk in and they're unresponsive and barely breathing, obvious signs. But right, yeah. So it's all based on vital signs, and they're getting an EKG in the house now. And you do the printout and it says STEMI on it. That's bad. That's someone having an active heart attack. You cannot diagnose a cardiac rhythm because we're not trained to do that. but you can put down a computer interpretation says this. And when you do a 12 lead, it prints out an interpretation of what the monitor thinks it is. And if it says STEMI or acute MI, and the patient's pale diaphoretic, that's a sick patient, we gotta go. So really it's gonna be based on your assessment, and you're gonna pick that up as you go. The more calls you do, the better your assessments get. And then you're also gonna have your vital signs. That plays a huge factor. Vital signs don't lie. The patient can tell you there's something wrong with them, and if the blood pressure is 120/72 and heart rate is 60, pulse ox is 98%, and you don't suspect carbon monoxide poisoning, vitals don't lie. Patients can lie to you. You guys remember the show House? Patients always lie. He's not wrong. Patients lie, or they don't tell you the full truth. And then you get to the hospital and you drop your patient off, and next thing you know, they're like, well, I also have this, this, and this wrong with me. And you're like, why didn't you tell me this in the ambulance? I could have different treatments for you, you know? And it happens because they feel that doctors are better. And they have more education. But we're the ones that are going to start this fast treatment on you. So again, that's why I always call patient interviewing interrogation because we're trying to get this info out of them. But yeah, so that's how you'd be able to tell those. Really, it's based on your vital signs and your assessment, what you find. Right? Did that answer your question? All right, awesome. So we're going to begin interventions needed to preserve life. If they are unconscious and barely breathing, we're going to breathe for them with a BVM. If they're in cardiac arrest, we do compressions, airway, breathing, defibrilation. If they're a diabetic and their blood sugar is low enough that they can still swallow, we can give them oral glucose. If it's a patient who's respiratory distress, we can give them CPAP. We can do inline nebs to kind of help them bronchodilate. There's a lot of different things we're going to do, but we have to intervene with these patients if they are sick. The days of taking a patient, putting them in a truck, and driving them to a hospital are done. We got to get out of that mindset. And that's something that's hard to change, especially with some of the older providers that have been doing this for a long time, where they used to just do the load and go criteria. And it's EMS has given us so much more. Okay, the physicians out there have said we can do this amount of stuff based on our scope of practice. Treat to your fullest scope. When you finish that call, you should be able to walk away and say, I did the very best I could for this patient. And if you cannot say that with every patient contact you have, then find out where you went wrong and fix that problem for the next patient you come in contact with. Because if you don't do something based on your protocol set, is that negligent? Yeah, it is. You are negligent to your patient because you did not treat them to your fullest extent. Now, you get a patient who is not breathing and you're by yourself in a BLS ambulance and you're stuck on airway and you can't get the breathing circulation, then you're stuck on airway. There's no fault with that, but you're keeping his airway open. Okay? If he goes into cardiac arrest, and we go to compressions, airway, breathing, right? But if your patient is unconscious, major bleed, tourniquet, and then we go back to the airway. Stop that bleed because bleeding is going to kill you eventually, right? And then you go back to controlling the airway. Absolutely. Don't try to think you're a hero at any level. Even as a paramedic, I call for other medics to help me. Trust me. I cannot do everything by myself. It's not about me trying to show off and say, oh, look, I'm the big paramedic here. It's not about that. It's about treating that patient. And if I need to call for another medic to help me out, absolutely I will. If they want to make fun of me, I don't care. You know why? Because I'm still going to go home at the end of the day knowing I did the best I could for that patient. It doesn't really matter. Integration of treatment procedures needed to preserve life. That's where we intervene. That's where our protocol sets set in. What medications we need to help with this patient. We need to give them aspirin, nitro, anaphylactic reaction with angioedema, swollen tongue. Do we have to give them epinephrine? Yes, we do. EMT level, epinephrine, left or right lateral thigh. In we go, right? Buys us some time to get a paramedic there to give Benadryl to stop that histamine release. We do not carry Benadryl at the EMT level, but the paramedics do. Call for them, right? They get on board, give some Benadryl, and then maybe they may have to give more epinephrine. Or if the patient's that bad, medics have epinephrine drips that EMTs cannot do. So, Socrates, you guys had a long ride to the hospital. Maybe that's what, an hour? sometime average hour transport to the closest hospital. Okay, here in the valley, average transport time 25 minutes, closest hospital. Right? Yeah. Berlin, 5 minutes. Right? Anywhere in the city, it's like 5, 10 minutes the longest. Let's go out to Milan. That's a different story, right? So again, and even still, what is that? 20 minutes, maybe? Okay. So it's not too bad. But 5 minutes with no airway, what's going to happen? Death. Okay. It's amazing what 5 minutes can do. 5 minutes. Yeah, just call every town you drive through. Standish, Gorham, Scarborough. Who can I get? It says what? I have not seen that, but I know what you're talking about, though. That's not even a skill that you guys would be doing anyways. No, those are NG tubes that go in. So they have to go down with a scope for those, and they actually they watch them go into the stomach. You can't just blindly insert those because it can cause a lot of damage to where the surgical site was. As far as what? Sorry, it's just. No, that's a very good thing to have because as the paramedic, we can put NG tubes into the field. So if we don't know about it, if you picked up on it and said, hey, the bracelet says no NG tubes, then that's good for us to know, especially if they're in cardiac arrest or if they have like a major GI, upper GI issue. We can put in NG tubes to help with that. So no, that is legitimate, something that we need to know, especially in the hospital. Because they say they have a small bowel obstruction. Okay, a lot of times they'll put an NG tube in. Okay, and if they don't know that they have that stuff done, they could cause more damage. So absolutely, yeah. No, that's fine. But it's still part of your primary assessment. If you have an unconscious patient, you need to find that medical alert bracelet to find out. Oh, it says diabetic. Well, there's our sign. Probably a diabetic. Check a blood sugar. Oh, it's 20. ALS, help me. I can't do anything else with this. Then we have the ALS will come in, AEMT or paramedic level will come in and give D10 to bring that sugar back up again, or glucagon, depending on their heart stick. So, no, good point. It brought me into the medical alert bracelet, so that's good. History taking. We're going to determine the chief complaint. So, chief complaint is not what dispatch tells you. It's a dispatch reason. You know, if I said to Taylor, why did you call EMS today? And he gives me an answer. I have chest pain. That's his chief complaint. Not the fact he had shortness of breath, but his real complaint is I have chest pain. Okay. Mechanism of injury, nature of illness. Was there an MOI? Was there an actual injury that caused it? Fall down the stairs, motor vehicle accident, you know, something traumatic injury, or the nature of illness, chest pain, shortness of breath, dizziness, nausea, vomiting, whatever it may be. Any kind of associated signs and symptoms, investigation of the chief complaint. So we have to then take our assessment and tailor it to what the chief complaint is. If they have chest pain, I'm probably not going to do a knee assessment on them. Okay. I will do an abdominal assessment, though, absolutely, with chest pain. But I'm not going to do a focused assessment on someone's kneecap. Right. So, patient past medical history and any pertinent negatives. Pertinent negatives being, do you have any chest pain? No. Shortness of breath? No. Dizziness? No. Nausea, vomiting, diarrhea, blurry vision, headache. If I ask a question and it's pertinent to the information with a negative response. Coming back. We're going to do a secondary assessment by performing a rapid full body scan, head to toe, pediatrics, toe to head, because you got to gain their confidence in kids. Again, all this stuff we're going to go over again. Assessment of vital signs, which I mentioned before, going through all your vitals, blood pressure and all that. Never leave a scene with one blood pressure, even a refusal. Okay, try to get a second blood pressure to make sure there's no change. Right? Now, they tell you, don't touch me again, I'm all set. Document in your narrative, patient only accepted one set of vitals. Okay, as long as you document it, and it covers you. Techniques of the physical exam, respiratory symptom, presence of breath sounds. Check lung sounds even with chest pain, because if you're having cardiac issues, it can lead to congestive heart failure, which then leads to pulmonary edema. So assess lung sounds. I've gone in depth on the competencies. We're really going to cover all these again. Technique of physical examinations. Cardiovascular, neurological, musculoskeletal, all anatomic regions. So we're going to teach you the different assessment techniques on the physical exam based on the complaint in front of you. Monitoring devices, non-invasive blood pressures, pulse oximetry, and added to 12-lead EKG. That's another one we're going to be doing as well. In CPAP. What was that? Because you're just going over it more in depth. The primary is quick down and dirty stuff to see what's really going wrong with your patient, like the quick down and dirty stuff, like, you know, and then you get into your secondary assessment, which is a little more detailed. The secondary assessment 10 years ago was called a detailed physical exam. Now they've changed the terms to primary and secondary to make it easier. No, it's a quick visual look, ABCs, you know, any life threats. Then we get into our secondary assessment, which then goes into our head-to-toe assessment. You can always call the hospital they were at and say, hey, I got this patient, bringing them in. We don't know what's wrong with this patient at all. We call med control. They don't know how to look up patients very well, like nurses do. But they might be able to give you some insight if you call in. Other than that, try to find, if you see discharge paperwork laying around, grab it. You know, try to bring them back to the hospital they came from. Now, if they had a hospital bracelet on, they came from Mass General, they're up here. You're not going back to Mass General, right? But Wentworth Douglas is owned by Mass General, remember, though. Not too far away. But we'll show you guys this stuff today. I'll grab a cardiac monitor off one of the trucks that's not in service, and I'll show you guys. Hopefully it's here. It might still be in Mass. We took it out the Holyoke for the St. Patrick's Day parade. All spare stuff. So how to reassessment? How and when to reassess patients? When we're going to do that? Every patient gets a reassessment. Okay, even patient refusals. Just do a quick reset of check of vitals. Vital signs, another note to take down as well if you're taking notes today. Stable patients, vital signs every 15. Unstable patients, vital signs every 5. That's something you're going to see in the National Registry exams. So all the cardiac monitors here, if you do ride time, are supposed to be programmed automatically when you turn them on. Vitals every 5, so you don't have to think about changing anything. It's set up for the critical patient, so you don't have time to start messing around with the buttons at all. Yep, as soon as you turn it on, hit the button. Hit button once and it does every 5. You can do it up to every minute, depending on how critical your patient is, especially if they're bleeding out. You get serial blood pressures like that. All right, so let's get into the introduction now that we've kind of went over everything once. Patient assessment is very important. It is. This is your basis of everything that we do in the assessment. EMTs must master the patient assessment process. Absolutely, you need to. But again, no one's perfect in this, but you got to study. You got to learn these things. A cardiac assessment is different than respiratory, which is different than neurologic, which is different than environmental assessment, depending on what's going on, right? All these different assessment techniques. We'll teach you all of those, but you got to practice them. You got to look at patients. You got to get hands-on. Patient assessment is used to some degree in every patient encounter. Even if the patient says, I don't want to be touched, I want to be a vehicle accident. You've seen those, right? I don't want to be assessed by EMS. All right, well, sign here. And as you're having a conversation with them, are you assessing them? Absolutely. airway, breathing, circulation, patient status. You're still talking to them, right? Every patient encounter has a patient assessment, and you need to document as such. If they're walking, talking, and moving, their GCS score is 15. They're alert and oriented, which allows you to sign them off, all right? And their airway is patent, their breathing is good because you're looking at their skin color and temperature, right? And you're also looking at their circulation, you're looking at all that stuff. Yeah, because you did. No, because you got to prove competency for them to sign off. Yeah, you got to show competency. Hmm? Nothing will come back at you because you didn't physically touch them. Now, if they say don't touch me and you touch them, then it's assault and battery, right? So you've made that threat, I'm going to touch you, and then you touch them. So assault and battery is there. However, if you and I are having a conversation, I'm going to document that we had a conversation. If you see them walking, I observed patient walking, and therefore a GCS score of 15. He's talking to me, his eyes are moving around like they should be, right? And he's moving around, good motor function, his GCS score is 15. You can do a lot of that stuff without even touching your patient. Now, if they're yep. I've done CPR on people before and given Narcan and they've woken up and walked out. You want to sign here? Nope. Down the road they go. It's like, oh crap. Document. You know, patient woke up, walked out of house, told us to, leave me alone, and walked out. Now in PD custody. No patient refusal obtained due to patient walking out. So there are 5 main parts of every call that we go on. Is your scene size up, your primary assessment, history taking, and we'll get into more of that here in a moment, and which acronyms we're going to be utilizing. Secondary assessment, and then reassessment of the patient. And all this stuff here also needs to be in your documentation, these 5 steps. All right, thank you. We know you guys are all set. I'll move forward. Good, good, awesome. All right, so rarely does one sign or symptom show you the patient's status or underlying problem. The signs and symptoms. Signs are things that you can see. Symptoms are what the patient tells you. Think of it as like if you see a stop sign, that's a sign, right? Okay, so signs are what you can see. Symptoms are what patient tells you. Symptoms are subjective condition that the patient feels and tells you about. Now, you're going to have elderly patients who are going to say, I just don't feel good. Well, what do you feel like? I just don't feel well. All right, let's start with this. Right. An hour later, you finally get that, they had a hard bowel. But they're going to tell you, I just don't feel good. Then you got to go into that investigation mode and interrogate your patient to find out what's going on. Right? You got to figure out what is the deal? Why are we here today? Right? Assign objective condition that you can observe with a patient. No, it's a symptom. And headaches are very important assessment findings as well, because depending on where the headache is located and severity of the headache, could actually be a head bleed. You know, other symptoms too, but not just that one, or it could just be that one at times. You know, so you got it's a lot behind it. So your scene size up, your evaluation of the conditions in which you will be operating on, right? So you're going to maintain situational awareness, which you talked about earlier. Always be aware of your surroundings. Don't let your guard down. Okay, you've got to be up and moving around, looking around, up, down, side to side. You don't know what you're walking into. Hoarder houses are dangerous. Okay, I've been in multiple hoarder houses in my time so far. And let me tell you, it can be scary when some of the stuff you can find in these homes, right? People live that way. It happens. No judgment, but you walk into these houses, you got to be aware of your surroundings. The last thing you want is to walk through, 8-foot high trash bags and they fall on top of you and bury you down. You don't want that to happen. Your scene size up combines an understanding of the situation and conditions prior to responding, your dispatcher's basic info, and then observation of what you see. You've got to look at it. Again, look around, look at your scene, look at your patient, look at conditions, all right? I've been on calls before where I've had to call fire in with SCBAs to get the patient out because we could not enter that home. And it wasn't because of carbon monoxide. It was because of other things that we found in the house. We just couldn't go in. It wasn't safe, okay? If that means delay in patient care, then so be it. But we're not going to put ourselves at risk to become sick or injured because the patient was in that type of condition. Get them out to us and we'll take care of them from there, right? What was that? Other airborne conditions of a home where there's other odors coming up that we can't get inside. Because they can wear SCBA masks where EMS cannot, unless you're a combination department, then you can do that, right? But a lot of places around here use private EMS, even though three-quarters of our roster are firefighters. Because we're working for this company, we can't put SCBAs on. We have to call the fire company to come in and do it. So there are situations where that may happen, other than this carbon monoxide poisoning issues. So just be aware of that. But again, was that? Yeah. Ensuring scene safety. So issues can range from minor difficulties to major dangers in the home. Do not enter until the scene is safe for you and your team. So let PD clear the scene first if need be. Okay. If you show up to a body shop and you see 4 people unresponsive on the floor, should you be walking into that building? Not at all. Because there's a chemical that probably spilled inside and knocked 4 people out. People just don't pass out like that unless they're all shooting up in the corner. But again, it could happen. But when you walk up to a body shop, you think that there's chemicals, maybe something got mixed somehow, some way, or something spilled. If I walk through that door, am I going to put myself in danger? Right? New Hampshire requires on every first in bag a carbon monoxide reading. This goes off if it meets a certain parts per million. Okay. So with that being said, if you walk into the home and the meter starts beeping, out you go. You don't go back in. The patient's unconscious at the top of the stairs. If you have readings of 1,000 parts per million, it's not going to take long before you drop inside. You're putting yourself at risk by even going into that building. If it goes off, it's high enough that it puts it at a dangerous level. Okay, don't go in without wearing an airbag. You're putting yourselves in a bad situation, right? So a lot of times you call for the unconscious patient or a well-being check and fire is not dispatched. What happens if you go in and you drop? Can you radio dispatch? No, because you're unconscious, right? What was that? No, but that's 20 minutes in, 20 minutes of potentially not breathing, right? So don't put yourselves in a situation where you can get caught, right? Call for help. Do not enter the scene. Typically, the way you enter the area is the way you want to leave, okay? But there are situations where you have to make holes in walls to get through or windows. I've had that a couple times. We had patients unconscious. We couldn't get him out because of the hoarding and his other situations. Wear a high visibility vest on roadways. Every ambulance is required to carry 2 vests in it, right? There's policies to wear them. Maine has a whole entire class in that with the DOT classes that have to be done for all new hires coming in. Maine DOT traffic control program and all that. Consider difficult terrain as well. So if you are not trained to do loading or rescue, then do not perform it. Call for specialized teams. Okay. If you need ropes in a Stokes basket and you're not trained to use that kind of stuff, you probably shouldn't be going putting ropes on, making harnesses and everything else. Right? Traffic safety issues. Granted, people might be good drivers out there, but they are always nosy and like to look at crash scenes when they drive by. Right? I'm sure we've all done that. Go look around. Right? No, not us. Right? Then a firefighter walks out. You get up. Don't park your ambulance. That's a whole different. Ambulance operations is different, but don't park your ambulance in a non-work zone. Remember, fire trucks are bigger than ambulances. Okay, they're used as blockers for a reason. So park in your work zone that's there. Consider environmental conditions. Okay, make sure you're wearing the right kind of foot gear and everything else, depending on what kind of department you work for. If appropriate, help protect bystanders from becoming patients. Keep bystanders away. More patients, more problems. Right? Hazards range from extreme weather conditions to treat the threat of physical violence. Yep, that's fine. An emergency scene is a dynamically changing environment. Absolutely it is, because you got to always be on your toes. You never know when something's going to change on you. Same thing with patient condition. Not everything is black and white, and you're going to have that fastball right down the middle. It's not going to happen. Your patients will throw you curveballs at times, and you got to be real ready to make that change in your assessment. Because there might be an underlying symptom that they just don't know or didn't tell you, and they can have that instant change. Like a patient who's doing perfectly fine, and finally their body can no longer compensate, and their blood pressure starts to drop. Like septic patients being one of them, and non-traumatic incidents. Right? They could be fine, next thing you know they're altered because their fever spikes. But constantly reassess your patients and constantly check on them. That curveball could be thrown at you, and if you don't catch that curveball or hit it, you're screwed. You're behind the game at that point. Right? And sometimes it's hard to play catch up. If the scene is unsafe, make it as safe as possible. And if possible. If it's not possible, then move to a safe location. Hazmat. You want to be uphill upwind or downwind downwind? Right. Okay. Away from the hazardous material. And the uphill is a lot better too as well because it rolls down hopefully. Once it's lighter than air, then you're kind of screwed with wind directions. But that's another whole hazmat class in itself. Determine mechanism of illness or nature of injury. Mechanism of injury, nature of illness. Call for assistance can be categorized as medical or traumatic or both. Why both? A diabetic that crashed in a car, and you get there and you do your scene assessment, you see a half-eaten candy bar. Maybe they knew they were going to have a diabetic emergency and couldn't finish the candy bar in time, and they crashed in a car. Check their blood sugar. You'd be amazed what people can do with muscle memory. Right. I transported a patient who had a diabetic emergency. Blood sugar was 10. He had 90% plasma burns over his body, so IV access wasn't possible. So I gave him glucagon and got him back. I woke him up. He drove 20 miles. It was the last time I remember, 20 miles. I think he was like in Hollis, Maine, or something like that. He ended up in Acton. It's probably longer than that. He just last year remembers was somewhere in the Hollis, Waterboro area, and he drove from that area to Acton, Maine. Is what is that? Half an hour, maybe, of driving because it was muscle memory. He drove that route all the time, but he was really just not there. Diabetic emergency. Then he finally crashed his car like a mile from his house. He went off into the rock wall. Minimal damage, unconscious. Fire got on scene before I showed up. And they're like, call for a helicopter, this and that, traumatic injury. I get there, I'm like, whoa, cancel all this. His blood sugar's 10. Let's fix this problem. Woke him up, patient refusal. They want to go to the hospital. It was just drove on a rock wall, but they treated it as a trauma. It could be a medical, right? Person driving down the road goes off into the woods, no skid marks, right? Could it be suicide or could it be a medical? Well, suicide's really medical as well, or psych. But could he have had a heart attack? No pulse, not breathing. Could he have had an MI and crashed his vehicle? Absolutely. So don't just rule everything trauma. It could be a medical condition that caused that to happen. Same thing with strokes, right? That can cause motor vehicle crashes. So I had a guy that shot up one day and drove in car accident. Gave him Narcan, woke him up. Told me he was going to the hospital anyways. He got in. We transported him. So a mechanism of injury is the amount of force, the type of or amount of force that is given. So car versus pole, car to car rollover, whatever it may be, fall from 20 feet off a ladder. How long the force was applied for, or where it was applied to the body, what type of force. So was it patient to steering wheel? Was it patient injected into a tree? Was it an ATV accident, snowmobile accident? Was it a fall down a flight of stairs, right? And where did that impact apply to the body? We're looking at fragile and easily injured areas include the brain, spinal cord, and the eyes. Okay, remember I mentioned in the class orbital fractures are here. Okay, very common bone that's broken, very fragile bones, which will cause raccoon eyes. Okay, there's something to pick up on. Look at the bodies of the area that it's covered. Blunt trauma is the force that occurs over a broad area. So if you have a baseball bat to the head, blunt force trauma to the head, right? If you have you're not wearing a seatbelt and your chest impacts the steering wheel, right? Anytime you have a crash, we'll cover this in trauma, but I'll kind of hit it now. There's 3 injuries that occur, 3 impacts, not injuries, 3 impacts that occur. Vehicle to object, body to the vehicle, organs to the body inside, okay? So it's not just hitting here. Everything inside you also has to move, okay? So you have vehicle collision, vehicle to object, body to vehicle, organs to body. That's your 3 impacts in a motor vehicle accident or a typical crash. Okay. So look beyond what you see in the patient conditions, organs where they're located. Right. Seatbelt across the chest, lap belt not placed in the proper spot. Right. Who puts their lap belt down by where their belt's supposed to be? Okay. Other than they put it right over their stomach. Okay. Now that's the wrong place to put a lap belt. It has to be down around your pelvis. Okay. Knee injuries, very important to pick up on. Leg injuries, especially in motor vehicle accidents, right? So they go down under the dashboard. Okay, that can cause knee. If they hit the knee, where does that force transfer to? Right, up the leg, through the femur, to the pelvis. Potential pelvic fractures because that pressure pushes up against it. Motorcycle accidents, what happens to them? Up and over, right? What do they catch on the handlebars? Where does it catch usually? Pelvis femurs, snapped femurs, broken pelvis, right? So you got to look at that mechanism of injury and what potentially could have for injury, especially if the patient's unconscious and you don't know, okay, what's going on. If they crash their bike, most likely they might have a pelvic fracture. So if they're unconscious and you palpate their pelvis like this, in and down, you feel crepitus, splint it. It's all based upon what you can feel, what you can hear on your assessment. Skin is usually not broken. Okay, sometimes it does, sometimes it doesn't. If it doesn't break, then we don't know where the fractures potentially could be. Right? You got to do your assessment and touch your patient. Tissues and organs are below the area of impact may also be damaged as well. Right? Your thoracic cage here protects heart and lungs. Okay, everything down here is not really protected. So you've got to palpate and feel, know where your spleen is, your kidneys are located, your liver, pancreas, right? Large intestines, small intestines, pelvis. Do your assessment, palpate and touch. When we do assessments today, later on, I'll show you guys how to do all that. Penetrating trauma, obviously the force of an injury that occurs in a small point of contact between the skin and the object, penetrates through. Open wound with high potential for infection, right? Maine has done a very good job with their new protocols with this for paramedic level. Maybe I'm drawing a blank, but at least at the medic level, they've given Reassessment antibiotic as a standing order now for open fractures, which is absolutely amazing. About time. New Hampshire has it only for the expanded scope, the X protocol, but Maine has put it in their protocol now for a 1 gram of Cephin IV, which is absolutely amazing to stop that, to start fighting that infection right away. Other name for it is ceftriaxone, but it's the same med, just different names, which is awesome. So good stuff is happening. Finally. For medical patients to determine the nature of illness, we have to investigate and find out what's going on. Similarities between MOI and NOI both require to use or search for clues: interrogation, touch, feel. Right? If you think you can get by EMT school without touching somebody, then you're in the wrong business, because this is really hands-on. You have to palpate. Right? You're going to be professional. Okay, what we do: 12 leads, women with big breasts. You've got to move the breast out of the way. You can't be scared and go around it down here, because you're missing the heart. Okay. So I've always taught this. This is groping. This is professional lifting. Back of the hand, lift the breast, apply your leads, put it back down. If you grope somebody, you can get in trouble. Right? If you, for some reason, have to do a 12 lead on a 16-year-old female and you're a male provider, have somebody out back with that, hopefully maybe a female out back with you when you're applying the 12 lead. Right? If you don't, you have to do your job. You have to do your job. Okay. That's why I say get them in the house if parents are around, and say, I have to do this. Okay. Never take off a woman's bra unless you absolutely have to. Okay. Keep their dignity. Now, traumatic events, the bra has to come off. Okay. Because it's actually hurting the chest area. So I don't uncut the back. I cut the middle right here. I cut it, and then it goes to the side. I cover them up. All right. I don't go back to that area again. Do my assessment, cover everything up, palpate the sternum. And when you palpate a female sternum, don't put your hand down on top of breast. Bad idea. Turn your hand sideways like this for palpation. And you push the sternum like that. There, you're not groping, you're pushing down. Sternum underneath the breast, lift up like this, around the rib cage, deep breath in and out. Feeling for crepidus, and that's all you have to do. You don't have to go back to that area again. Cover them back up. Keep their dignity. Okay? Keep everything intact. Be professional. I mentioned that because that males, it's easy. We can take our shirts off, we can palpate all day long, right? But with the females, it's a little bit different. You got to give them respect, okay? And work with it. It happens, but you are a professional provider coming in. Talk with the patient, family, and bystanders. Ask questions, right? But if you're talking to a patient or talking about to you, and there's a bystander or wife, husband, whatever, and he's butting in, they've got to stop. You got to put a stop to them talking and say, listen, I need to assess them first, and we can have a conversation after. Right? So don't tell them, shut your mouth, don't talk to you. You can't say that, right? Be professional, be courteous, and listen, I need to assess them, and I'm waiting to hear back their answers. Well, he has dementia. Okay, but I want to hear what they have to say first, right? Because that helps me judge where they're going, and then I can talk to the family and say, hey, so what's really been going on here? Use your senses to check for clues. If you suspect something is wrong, something's probably wrong. If it looks like a duck and quacks like a duck, don't search for the zebra. Okay? It's a duck. Right? Was that? Okay. Let me just finish this last one here. We've only gone 23 slides in an hour, so. Be aware of the scene with more than one patient with similar signs and symptoms. If a lot of people are sick, that should be one of those, oh, it's a clue that there's a problem here, and I don't know what's going on. Should I even be here right now? Or should we start evacuating the premises? Could it be food poisoning, right? Large commercial buildings that have a cafeteria, they all eat the same thing, and everybody now is vomiting, right? That could be a problem. It's a clue to figure out maybe it's a foodborne illness, okay? So looking around at your surroundings, if more people are sick than just the one, you probably should think, hey, should I even be here? Or should we start making our way out? So carbon monoxide poisoning being one could indicate an unsafe scene for the EMT as well. All right, let's take 5, stretch, then an hour, and then we'll continue on.
This conference will now be recorded.
All right, so importance of MOI and NOI, we're going to consider the MOI and NOI early. Considering this early can be of value in preparing the patient for transport. So understanding what they went through and how they crashed or what kind of medical condition they went through will actually help us determine our transport, what we're going to do during transport. Do we need to call an ALS intervention? Do we need to do early notification to the hospital? Is it a STEMI? Is it a stroke? You know, things like if you see the heart attack signs in the interpretation says STEMI on it, we're going to take that EKG, we're going to push a button on the cardiac monitor, we're going to transmit it to their fax machine so they can see it. The doctor can go, yeah, that's a STEMI, let's start prepping. Or if it's a stroke alert, we're going to call in a stroke alert early so we can get pre-registration done so that there they can get right to CT. So like this area here, we don't go to the ER beds with strokes. We go right to the CAT scan, right to the CT right off the bat. We drop them off in there because early recognition is what they need to have because they get time as well in hospitals. So understanding both sides of that really does help. It helps because you're prepping them to get to the ER, but the ER also has this time frame to get patients out the door to another definitive care. So around here, these are called critical access hospitals in this area. So they can start stroke treatment, but they don't have interventional neurologists here. They have to ship them down to Portsmouth Hospital. Sanford Hospital, they don't have anything for neuro intervention. They have to go to main med, right? So there's other hospitals that have higher levels of care. That makes sense? Okay. Yeah. Right down to Portsmouth because Portsmouth's level 2 trauma center. The only thing making Portsmouth not a level 1 trauma center is they don't have a teaching affiliation with a major university. Other than that, they have 24-hour neurosurgeons on staff in the hospital ready to go. There's only one level 1 in the state. What was that? Yes, Maine Med is the only level 1 trauma center in Maine. Dartmouth over in Lebanon, New Hampshire is the only level 1 in New Hampshire. Portsmouth is not far from getting it, right? And then you go down to Boston, and there's quite a few. Not as many as you would think there would be. Like Boston Children's is not a level 1 trauma center, right? Boston Children's Hospital doesn't even take burn patients, kids. They go to Mass General, then they get transferred to Shriners. So it's interesting how that Leahy Burlington is now level 1, which is nice. So you may be tempted to categorize patients immediately as either trauma or medical, but fundamentals of good patient assessment are the same. Okay. Yeah, this is trauma. Yes, this is medical. Yes, this is the medical trauma situation. Either way, baseline vitals, go through our patients, assess them, treat them. Whether it be medical or trauma, we still have a job we have to get done. Standard precautions, we talked about this pretty heavily already. You need to wear standard precautions: mask, goggles, gloves and mask on every patient. Okay, safety glasses. This is a chest pain. I mean, I probably wouldn't wear them all the time, but again, follow your local protocols, okay, and what your state requires you to wear. I always keep gloves in my pocket on my EMS pants. I carry extra large gloves in my pocket at all times. If I get covered in blood, they come off, new ones go on, right? Standard precautions have been recommended for use for dealing with objects, blood, bodily fluids, and potential exposure risk of communicable disease. Okay, like airborne pathogens, COVID being one of them, flu, tuberculosis, things like that, like airborne. We could come in contact with. When you step out of the EMS vehicle, standard precautions must have been already taken or initiated. Have your gloves on before you get out of the vehicle. Now, if you are driving the ambulance to the hospital, please, for the love of God, take off your gloves. Take off your gowns, and do not bring whatever you just touched a patient with in a house into the front of the ambulance. Right? Take it all off, leave it in the back of the truck, get in the front, and drive. Right? When you get back to the hospital, then you get out, put on new gowns, gloves, whatever you have to do, and then take the patient indoors. Right? Do not be the one to drive down the road with purple gloves or down the road with a steering wheel. Right? Because if you put those things on, and you start touching everything inside, what is the first thing you guys want to decon the front of the truck after a call, right? How often does that happen? Right? We always forget about the front. So you get back in, oh, that was a great call. Good job, guys. You're touching everything with your hands. Lo and behold, the driver who was up front had their gloves on, and they touched everything in the front, radio and everything else. Now that you've basically just destroyed everything you've done, right? Don't get in the front of the truck until you're taking stuff off. Okay. Yes. Yep. So we always wear a mask in a home. Lately, I've been seeing a lot of law enforcement officers and things like that not wearing masks at all anymore, but we have to. It's company policy here for our company that I work for, which means that on your ride sites, you guys will be wearing masks on all your calls as well. And the hospitals require them. You have to have them on inside the hospitals. Determining number of patients. So during your scene size, I've accurately identified the total number of patients that we have. This is critical in determining the need for additional resources, what we're going to need. Do we need more ambulances or not? When there are multiple patients, use the incident command system, identify the number of patients, and begin triage. So I'm going to leave it at that. Beginning triage. We're going to cover triage in depth in this program, right? I don't want to hit it too hard now. So triage is the process of sorting patients based on the severity of each patient's condition. It's a quick assessment and leaving a tag on the patient, moving on next. One of the hardest things you're going to do, because the patient's about to die, we let them die. We move on. Okay, it's going to suck. It's going to be a horrible thing to have to leave somebody there to die, but we got to try to save as many patients as we can. Not focus on this one. All right, we'll cover that later. It's a tough thing to deal with, but you got to do what you have to do to preserve as much life as possible. All right, there's a whole flow chart how to use it. We'll cover that later. Consider additional resources or specialized resources. Some situations may require more ambulances, or if we need like hazmat, extrication teams, specialized tech rescue stuff, whatever we may need. Fire departments come in. So again, based upon what you have. Right? You got a car that went over an embankment. The embankment's like at an 80-degree pitch going down like this. Right? Are we just going to walk over the edge and go down? No. That requires ropes, totes, baskets, and the right equipment and trained personnel. So all it's going to take is for one of us to go over not trained and we get hurt. It's like someone with ice rescue. You don't put on a suit if you don't know how to use it, right? Or use specialized equipment. If you don't know how to use the stuff you're trained in, it's there. You're going to put yourselves at risk and you become a patient yourself. Or the patient dies because you don't know what you're doing. Other specialized resources will be ALS or air medical transport. So calling for DART, Life Flight, Boston Med Light. All those are valuable options that we can utilize in this area. Right. They're not coming from too far away. Even Boston can be up here in half an hour in this area here. ALS, know where your ALS intercepts are going to come from. Fire departments for high angle hazard or water rescue, law enforcement if needed to protect, right? To determine if you require additional resources, ask yourself, does the scene pose a threat to me, my patient, or others? How many patients are there? And do we have the resources to respond to their conditions that they have? If you don't, then you need to call someone who does. So the primary assessment begins when you greet the patient. Hi, my name is Kevin. I'm a paramedic. I'm here at the ambulance. Right? That's when our patient assessment starts. The goal is to identify and initiate treatment of immediate and potential life threats. If I see something that needs immediate attention, I give it to them. If they are short of breath, they're going to get oxygen. Get a pulse oximeter. I'm going to check it really quick and see what the readings are. So I want to get a room air saturation document. Then non-breather, nasal cannula. If they're unconscious and they're barely breathing, back valve mask ventilations. Right? We treat the patient. Immediate life threats are dealt with. Physical exam of the patient and assess loss of consciousness or level of consciousness. Okay, so remember the AVPU scale again: alert, verbal, painful, unresponsive. And then our ABCs: airway, breathing, circulation. Right. So once we've established this part, we need to form our general impression. If you need me to go back, let me know. I'm kind of going a little fast with this. So are you good? And unresponsive. Yep. So AVPU, AVPU they call it. So alert, verbal, painful, unresponsive. So we're going to form our general impression, sick or not sick, formed by determining the priority of care. The patient's sick, we got to move fast. Patient's stable, we can stay and play a little bit, which is first part of the primary assessment. What is our general impression? We're going to make a note of the person's age, sex, and race, level of distress, and overall appearance. Right? Females present different than males in certain conditions. Right? The typical female heart attack may present as a silent, or they may say, I have back pain between my shoulder blades, and that's it. And they're having a heart attack. Whereas the typical male, chest pain, right into the left arm, numbness, neck and jaw pain, where females may present different. Diabetics present different also because of neuropathy. The neuropathy may cause a diabetic to present differently. So some races present differently. Excuse me. One would be like for African Americans with sickle cell anemia, where white population may not have that. Actually, do not have that. Shouldn't say may not. They do not have sickle cell anemia. So we'll get into that more in the medical conditions and emergencies, but they may present a little bit differently. Yeah. No. Right. To me, everybody gets treated the same. Male, female, African American, white, doesn't matter. They all get treated the same with me. And so I don't try to stereotype anything, but I have to ask specific questioning, to see which way I'm going to go with my treatments. I had a thought that I wanted to bring up in the class for that. I just lost it. Yeah, I'll need to pause this for a minute.
This conference will now be recorded.
All right. Sorry about that. I thought they were going to do the medic tones and everything else. It's been worrying about. I lost my train of thought with that. I had something I wanted to mention to you guys about the different race stuff and all that. But... Oh, I remembered now. Thank you. You mentioned that word and I just thought of it. Different races have different needs and beliefs. Just keep that kind of stuff in mind as well. Exactly. Yes. And you have to follow their beliefs. Okay. Don't force anything upon someone they don't believe in. Ask them. There are some procedures and different exams that females may not allow males to do. And you have to follow their beliefs and their wishes. Yes. Right. So one of the things that I learned that I was working as a manager one time at a hotel years and years ago, we employed a very high Somalian race, Somalian population. Let me tell you, they were very good at their job, but they smelled horrible. And I asked them, I didn't know. I'm a young manager, keep in mind. I said, I have to talk to you about your hygiene. I said, because there is some odors, we need to take care of this, and what do we need to do to help you? And they go, well, it's our religion that we cannot use body soap. They're not allowed to. That's what they told me flat out. We cannot use soap on our body. I said, I didn't know that. Now, can I enforce that now? No, I can't go against their beliefs. I had no idea. And I apologized to them and said, I'm very sorry, and I was very polite about it. They said, no, not many people know about this kind of stuff. So do they have poor hygiene? They bathe every day. It's just they don't use bars of soap. Interesting, right? So I never would have known that until I asked. Don't be ashamed to ask a question, okay? Because I don't expect any one of us in here to know every belief of every religion that's out there. I have no idea. There are some religions that cannot receive certain blood products. They just don't believe it. You know, it's against the religion for that to happen. You got to, you know, respect their wishes. You know, there's medicine out there to treat mostly everybody, right? Obviously, the conditions that are untreatable, but there's medicine, but you still have to follow the religious beliefs behind it. So I know blood products is one, and I can't remember which religion it is in belief. And I just can't think of it. Yeah, so you guys, yeah, and you still got to follow what they believe. You know, so there is nothing we can do in our field of work, but get them to the hospital. And there's other ways they can get social services involved and start certain treatments. But that's something way above us. I know there are ways of getting certain rights pulled from parents to get kids treated. But again, that's physicians talking with caseworkers and stuff that way above us, way above what we have to worry about. The thing is, though, is what are you reporting? Their beliefs, you know. Now we get them to the hospital. Our goal is to get a patient from point A to point B to definitive care, right? So if they agree to go but don't want anybody to be touched, we document that as such, and we get them to point B, where they have physicians and other people of higher power that can make decisions with these. The parents have total control of what happened. Even if the child's asking for help, the parents would say, no, I don't want my kid touched. But that's what other divisions of courts and judges and can make certain determinations at that point. No, they don't have that kind of power. Yep. As long as you document what happened and then they refuse care but accepted transport, then you're covered. You have to document all that stuff and let them know. And even have them sign a refusal form. You're signing off saying that you don't want me to touch you, but we'll take you to the hospital. It's not on us. Yeah. Now, I have not run into that much. Very rare that I've ever seen that. Maybe a couple times in my career where I've seen that happen. But there are judges, social workers, and everything else that follow in that legal system that can make changes. Our job is to get them there and report that to the physicians who then can take the next step from there. Right. But the main goal is get them to the ER and then let them handle it from that point. Yeah. It's tough. It's tough, but our job is to show up and treat what we can treat and help what we can help and get them to definitive care if we can do it. You can, if you feel like you need to report it, you just call Department of Health and Human Services and just report that. But the nursing staff has to know, and you have to just let your chief know you're making that report so they know. But following a belief might not exactly be abuse. You know, there are some people that don't believe in medicine; they believe in more of the holistic medicine versus other medicine that's out there. You know, it's just I have not run into a lot of that yet. But again, also look at the areas we live in. You know, you may see that more in bigger city stuff versus backwoods country EMS. And rural versus city EMS, completely different, by the way. So if you get a chance to do city EMS at some point, take advantage of that. It's a whole different world. If anybody is aspiring to be a flight medic someday, if you are, okay, you have to be good at IFT, rural and city, 911, and interfacility transport. So if you want to become a flight medic, that's what you have to do. And man, master this stuff. It's tough. So form a general impression. Avoid standing over a patient. That means you're overpowering. Get down to their level. Okay. That's why I said look before you kneel down. Right. Especially with kids. Get down to their level. Address the patient by name, Mr. or Mrs. Right. And they say no, just call me Julie. Okay. But always address them by Mr. or Mrs. at first. Give them that respect. And if they tell you to call them by something else, then they're giving you permission. Do you mind if I assess you? They say yes, you can touch them. They say no, then that's battery if you touch them. Introduce yourself, who you are. You are going into somebody's home, talking to a patient you've never seen before for the first time. They're supposed to trust you. You know what you're doing when you walk through that door. Okay. Mm-hmm. I do the best I can to convince them to let me touch them, but they're adamant. They say no. Then all right. Then I see you sign a piece of paper here, letting you know that if anything happens to you and you were to take 2 steps, fall, and die, it's not my responsibility. You know. And they're like, oh, well, in that case, you mind taking my vitals? Okay, thank you. It does happen. And you got to just paint the picture that if you don't get a chance to assess them and you walk out that door and if they pass away, we're not held liable because you do not let us assess them. You got to paint that picture. And I pissed off some people in the process of doing that, but I have to cover myself and my license. My paycheck feeds my family. And if I can't bring that stuff home to them and I lose my job or go to jail because someone died, what good am I to my family and myself? So I got to cover it. Yep. Yep. Okay, let's go. Hop in. At least we're getting in there. But still, try to do your best to get that assessment in them. Right? And you're going to come in contact with retired nurses. It happens. No. I don't know how. I know how to put it in. We cannot do that in the field. Um, uh, ask about the chief complaint. Why did you call EMS today? Let them know. Let them tell you what's going on. Don't interrupt them. Now, if they go to a life story for 20 minutes, back down a little bit. And we've all seen that where they just keep going and going. It's like, whoa, let's go back to why are we here? Oh, well, my knee is swollen up. Okay, great. Let's focus on that. Okay, how long has it been swollen for? Oh, about 3 weeks. Okay, do you have arthritis? Oh, I do. Okay, have you taken any Tylenol or any NSAIDs? No, I haven't taken any. Well, right. Well, here's 400 ibuprofen. Let's take a ride to the hospital. Let's get over there. You know, address any life threats immediately. So, if there's any life threats, take care of it. Determine if the patient condition is stable, but potentially unstable, or unstable. So, sick, kind of sick, or hey, you're pretty good, right? We got to make that determination, and that's going to be based on our primary assessment and our secondary assessment and everything else. Like, how do they look? How do they feel? If they go like this and they squeeze their hand over their chest, showing this is Levine's sign, by the way. So this is usually like something that's non-cardiac. This is usually cardiac. Don't judge your whole assessment based on that, right? But if they hear, they go, oh, my chest is squeezing, and they're pale, and there's a puddle of water from diaphoresis. That's a sick patient. They're having some kind of cardiovascular event. Whether it be a heart attack or whatnot, who knows? That's for us to determine more. But they're a sick patient, right? Squeezing on the chest, radiating into the left arm, jaw pain, diaphoresis, gray ashen color. That's sick. That's a very sick patient. Probably going to die on you in the next 5 minutes. Then you got to go quick. But those are your sick patients. If they're sitting here like Nick right now is staring at me right now, is listening to this lecture, and he looks perfectly fine to me. I see nothing wrong with you at this point in time for the general impression. You do not appear to be sick. Doesn't mean that you aren't. You could be compensating right now, and I don't know about it, but I'm going to do more of an assessment to find out. But my initial general impression for Nick is he is not sick. Right? That's your determination. You walk through the door and go, oh, crap. We've all had those patients where you walk in and go, huh, I'm going to have to work today. You know, and then there's those are your sick patients, so we have to deal with. So assess level of consciousness, right? AVPU, and then determine the level. Are they altered or are they not? Person, place, time, and event. CAO times 4. Conscious, alert, oriented times 4. Now, if they're conscious, alert, oriented times 2, which 2 are they oriented to? Person, place, time, or event. Which one is it? I want to know that information. That's important. If they know that the president is Biden, they know that we're in March, but they think it's a Wednesday when it's a Friday, and then they think it's 1922. I know that 2 of the 4 are correct. I'm going to document that. They knew month, they knew the president. They didn't know year and day. Right. So determine what that is. Which one are they oriented to? If it's all 4, then it's CAO times 4 in a person, place, time, and event. CAO is the abbreviation for conscious, alert, and oriented. You can do that, alert and oriented. I do conscious because that conscious part is also important too. So I do CAO, you can do AO, either one is fine, right? Unconscious, conscious with altered LOC, or conscious with an unaltered LOC. So they either unconscious, or they conscious and confused, okay? Now, dementia patients are normally confused, right? Alzheimer's, dementia, right? They're confused at times. So their GCS score is going to be a 14, not a 15, because their verbal response is going to be a 4 instead of a 5 because they are confused. So the next question is, ask somebody else, is this baseline for him or something different today? Okay, that's what you have to find out. Is their baseline different? All right, that's an important factor, is the baseline of the patient. If it's like a pediatric, same thing. Is he acting normal to you? Wasn't that your job to figure out? No, because I don't know what his normal is, right? You have to tell me that. You're the parent. Are they acting normal? Well, no, they've been sleeping more today than they normally have. Oh, okay. Well, that's different, right? Something out of the norm. Now I can work with that. I can start doing some more assessment techniques to find out what's going on. You got to find out what is normal. And that's going to be an important factor for stroke assessment because you have to know the last seen normal time. Because they got a window, okay, when they can start receiving clot busters like TPA. We have to report that to the hospital for strokes. When was the last normal time? They don't know, then they don't know. Just document that unknown, right? And that may determine whether or not they get TPA or not. They've opened that window up now to 24 hours. It used to be 6. They've done a 24-hour window now. The new AHA stuff, American Heart Association stuff. So, but again, not our determination to give medicine like that. That's up to the physicians and neurologists. But still, try to get the last known normal time. And that could have been when they went to bed 10 o'clock at night and they woke up like that. So last known normal is 10 p.m. They could have happened at 2 a.m. The stroke could have started while they were sleeping. But determine level of consciousness. We're going to assess an unconscious patient by focusing on the airway, breathing, and circulation. Sustained unconsciousness should warn you of critical respiratory, circulatory, or central nervous system problems. Patients should not be unconscious. We got to figure out why, right? Was it a stroke, head bleed, cardiac symptoms? Is your heart rate 30? Is it cardiac? Is it a diabetic emergency? We don't know. Alcohol intake, drug overdose. Is there a note laying around? Are there pill bottles laying there? Is it an elderly person that took their night medications and took them again? And they're on beta blockers, their heart rate's 30. Good to know. That's a paramedic level call. Okay. We have to give certain medications intravenous to help reverse that beta blocker overdose. Okay. So there's a lot of things to look at. Medicine, pharmacology is so important to your assessments because those medicines can change things. A patient that's on a high beta blocker can mask sepsis with high heart rates because we're controlling the rate of meds. So looking at medical history, okay, that's where our samples that come into play later on. We talk about sample history. These medications is part of the M in sample, right? So we look at all this information. Now I'm throwing a bunch of different points at you right now. Eventually during assessment, all of this will come together and be like, huh, that makes sense. right? And it's going to click. But having having the knowledge of pharmacology, medications, assessment, looking at their medical history, everything else. Like let's say you get to a patient who is unresponsive and you don't know their medical history, but you find their med list. You can tell a lot of what it potentially could be based on their medications, right? If it's accurate and current, but it gives you at least an idea what to look for. Okay. Pill bottles. Yeah, so you made a mention about that earlier. How many are left in the bottle, right? So if you find someone who's unconscious and there's a pill bottle laying next to them with nothing in it, and you look at the bottle, quantity 30, take one per day, filled 2 days ago. Oh, maybe they overdosed on the medication that's here, potentially. So you look at all the different clues you may find on your size up and see what potentially could be wrong with your patient. Nope, not at all. We have to know exactly what they're taking. Conscious with an altered level of consciousness may be due to inadequate perfusion. Right? Check cap refill. Push on the skin and let it go and see if it returns back to color. 2 seconds is normal. Anything more than 4 seconds is considered low circulation. So if everybody takes their hand and pushes on the top of their hand right now and let it go, you'll see white and the color should come back within 2 seconds. Okay? If it stays white, continuing as it stays white, right? Hands are always cold? No. All right. No albino checks. All right. But I mean, also remember Raynaud's syndrome is also continuously cold hands, right? But then check the feet, check the skin, push up here like this. You should be able to get good color back everywhere you go. Okay? But pressing down. That's called capillary refill. That's how you check good perfusion. Also, is perfusion circulation of blood within the organs and tissues. So here, patients and little tidbit of information. If patients are in shock, the first organ to fail is your stomach, right? So you may have patients that with nausea. So you say, oh, I need a paramedic here. They can give Zofran. Zofran is not going to help that. There's no antiemetic that will fix that. What they need is better perfusion because they're going into organ failure, right? So patients that are in shock, we have to do other treatments. We'll cover that later. It could also be caused by medications, drug, alcohol, or poisoning. Poisoning is a whole different world. There's different things, different indicators of a potential poisoning. They're called toxidromes. Toxidromes are a series of indicators based on patient presentation that will indicate a type of medication overdose they may have taken or poisoning of some sort. Like opiates, for example, would have respiratory depression, altered mental status, and decreased respirations. Okay. There's anticholinergics, cholinergics, antihypertensives, a bunch of ones that are out there you'll learn. We talk about toxins later. I'll show you guys all the different toxidromes in there, and I have a handout for you as well that I made. That's different. That's because you're not in shock at that point yet. But you're still having circulation, unless the body's in shock and you're tachycardic and hypotensive, right? But sometimes just the cardiac event will cause that nausea and that burning as well. So to assess for responsive, talk about AVPU, awake, verbal, painful, unresponsive. So we're going to test, I'm going to show you this here next. We're going to test responsiveness to painful stimuli. You can pinch the earlobe, press down on the eyebrows, pinch the neck muscles. That's called the trapezius pinch, the muscles up here. Basically, your trapezius muscles, take when you pinch them, all right? You can really drop anybody with those if you push hard enough on that, it actually hurts. You can try it on each other if you want. But just applying even a little bit of pressure, you'll feel the pain there. It doesn't hurt until you really grip down. Huh? You got you. You're good. All right. Uh, orientation, test mental status. Okay, we have to know what mental status they're in. So person, place, time, and event. Moving forward. Evaluate long-term memory, immediate-term memory, and short-term memory loss. Okay, if someone has a head strike, check short-term memory. Ask them to remember 4 things. Okay, purple, pink, yellow penny. And in 5 minutes, I'm going to ask you to remember those again. Make sure you write those down yourself. Okay, in case you forget. But again, if they can't remember 4 simple things, then they have short-term memory loss. Okay, so make sure you right now. If you use the same thing all the time, and you'll know what they are. You test these patients, but if you forget, it defeats the purpose of what you just did. Any deviation from the patient's normal baseline is considered altered. Okay? Any deviation from it. Conditions that cause sudden death. That's bad, right? Airway obstruction. You can't get to breathing if they don't have a patent airway. Right? So abdominal thrust. We can no longer use the word Heimlich anymore. They got all pissed off about that. So now it's called abdominal thrust. Airway obstruction, clear the obstruction. Respiratory failure, we need to ventilate and make an airway for them. Okay. If they're in failure, we have airways to put in at the EMT level. We have King airways. Okay. Respiratory arrest. If they're not breathing, we got to breathe for them. Again, shock. If they're in shock, we have to treat it. Keeping them warm, applying oxygen, putting the patient in what they call position of comfort. Okay, that's the exact term. Right. Trendelenburg still exists. Raising the legs up 12 inches, allowing the blood flow to go to the core. Okay, that's another option that we have. Right. Keep the patient warm, lie them down flat. Firefighters in the room? Right? Who's been through fire school already? Okay. What's the difference between concentrated and distributive load? Okay. And distributive does what? Spread out, right? If you have a person stand up, is it concentrated or distributed? Right. If they lay down, what happens? If you distribute something over a space, does that make it easier? Right? Less weight makes it easier. Better for the heart to pump if you're lying down and standing up. That make more sense now? Right? So you put things in fire terms, it works. You wait till I get to cardiology. Yep. You lie down flat. That's fair. Wait till we get into hearts. We'll start bringing the heart to a fire pump. Listen, there's LVHs, 2.5 inch and 3/4. It's all the same. You have vessels in your body. Heart's a fire pump. Instead of pumping water, pumps blood. You need a cavitation, it's bad. Right? So, severe bleeding, if you continue to bleed out, you die. Okay? So if you have severe bleeding, we got to tourniquet it and move forward. It's going to hurt the patient, but you at least stop the bleeding, right? For primary cardiac arrest, remember compressions, airway, breathing. ABCs go away and it goes to CAB. In most cases, begin with airway, followed by breathing and circulation. Again, you can't get the B and C until you fix A. However, if they are bleeding out circulation, right, I have to fix that first. Tourniquet and go back to airway, right? Any immediate life threat that's going to kill somebody, let's stop it. Remember I mentioned before, femurs, pelvis, they hold a lot of blood. Your body has between 5 and 6 liters, depending on body size, for all the adults that are here, okay? Your pelvis can hold 3 liters of blood. That's half your blood supply. A lot of blood to hold into, right? Half of your blood supply can fit in your pelvic cavity. That will tank your blood pressures and potentially put you into cardiac arrest because of hypovolemic shock. Right? That's why it's so important to stabilize, splint, stabilize. In some cases, it may be appropriate to address life threats to circulation first, like I mentioned before. It may be time to stop bleeding before you get back to airway. Because you can control that airway and try to fix it all you want, but if they bleed out, they're going to die either way, right? So fix something that you can fix. Tourniquet, move back. So assessing the airway, move through the primary assessments to alert for signs of airway obstruction. If you see an airway obstruction, remove it. If you don't see it, abdominal thrusts, okay? Or if they're unconscious, chest compressions. Ensure the airway remains open, patent, and adequate. Responsive patients. Patients who are talking or crying have an open airway. Watch and listen to how the patient speaks. Do they sound like the hoarseness here, right? Things to pay attention to. Patients that come out of burning buildings. Patients that have gas grills that blow up in their faces and have burns. Superheated gases causes airway swelling. Okay, they may be fine now and have a hoarse voice, but remember the heated gases that come in and you inhale will eventually swell and swell and swell to the point where it blocks it off. Okay, so those patients need ALS intervention. Some that are really bad actually need to be intubated before it closes up around. You can't get a tube in. Once that closes, the only other option is cutting a hole. Medics don't want to do that. I don't want to do that. I don't have to, right? I have never done that before, nor I ever want to. We have the option to do surgical and needle, okay? We have something called quick trace, you just pop it in. But I don't want to do that. I got to find the lamp. I know how to. I could easily probably do it. I just don't want to do that. That's like a last-ditch effort. No. No. Yeah, I'm good. So watch and listen to how your patient speaks. Okay, again, they sound hoarse, there could be an issue. Look at their airway. Stick their tongue out. Say, look inside. How does it look? Right? Singed nasal hairs, nasal passageways, means they got superheated gases in their airway. Right? If you identify an airway problem, stop the assessment and work to clear the patient's airway. Okay, vomiting is another one. If they aspirate, which means back into airway, vomit into airway, that's bad. Fluids are not supposed to be in there. That causes infection. You can get pneumonia pretty quickly. It's called aspiration pneumonia. That can also turn into sepsis and kill somebody. So again, this is above and beyond what EMT does. There's the ability to paralyze and sedate people, which we will have hopefully by the end of April, where you give medications to sedate them and paralyze them and put it to. It's called RSI. Conway Fire has it. Huggins Hospital medics have it. We can call for them right now until we get it here. It's called rapid sequence intubation, where we can sedate and paralyze. But again, if you think you need it, though, good. I'm glad you're thinking that way. Because if you say, "Hey, this patient airway is probably going to close up on me. I feel very uncomfortable with this right now," call for ALS. In New Hampshire, there are multiple services out there that have RSI capability. In Maine, White Flight of Maine is the only one that has it, the helicopter service. Unless you're in the Sanford area, then they have the ground. They have the ground unit at Sanford Airport. Yep. All right. Unresponsive patients, immediately assess the airway. We're going to use a jaw thrust technique. So I'm not going to do it to myself or anybody else that it really hurts. You're displacing the jaw up and out to open up the airway to get that tongue out of the way. Then you put an OPA in or NPA. We'll talk about those later. Head tilt chin lift for your non-traumatic. So jaw thrust for trauma, head tilt chin lift for non-trauma. And then relaxation of the tongue muscles is a cause of airway obstruction. The most common airway obstruction we're going to come in contact with is the tongue being in the way. So we have what they call an oral pharyngeal airway device that we put in, which I'll go over with airway management. We put in and it displaces the tongue up back in a normal position so you can allow ventilations to get in. What was that? Yeah, I call them devil babies. Their tongues are always in the way. Popsicle sticks work great. You can displace the tongue and put the airway in that way. But yeah, I call them devil babies. Signs of obstruction in an unconscious patient, obviously obvious trauma, blood or obstruction, and secretions, we got to suction out. Noisy breathing, snoring, bubbling, gurgling, throwing, or abnormal sounds. Okay, like seal bark, coughs, in kids that we can more consider croup, right? Where the airway starts big and it goes into what they call, in an X-ray, you'd see something called steeple sign, but their airway looks like a steeple coming up like this, and it's really narrow because their airway is swelling. And then they bring them outdoors and it goes away because the cold air relaxes it. But that would be a croup, seal bark, obstruction. Extremely shallow or absent breathing. So again, anaphylaxis can cause all this. Medications can cause airway swelling as well. One of the biggest ones that I've come in contact with that you'll see is lisinopril. Lisinopril can cause angioedema, which is swollen tongue. And it's interesting because you could take it for 5 years and not a problem. And all of a sudden, one day, you have a reaction to lisinopril. So, blood pressure. It's an ACE inhibitor. It inhibits the it's an angiotensin converting enzyme inhibitor, which works in the renin-angiotensin and a bunch of stuff. Nothing I want to cover in this class, but it inhibits, the ACE inhibitor inhibits that conversion over to help reduce blood pressure, in simple terms. But that can cause angioedema or swelling of the tongue and have a reaction to it even 5 years in. So ACE inhibitors can be dangerous sometimes. Make sure the patient's airway is open with assessing breathing. Make sure the patient's breathing is present and adequate. And ask yourself, is the patient breathing? Number one, is the patient breathing adequately or is it irregular? And is the patient hypoxic? Okay. If they're hypoxic, what you're going to see is like tinted blue. All right, that's called cyanosis. Cyanosis would lead to hypoxia, right? Or indication of hypoxia. Pulse oximeter, low pulse oximeter readings, hypoxia. Anything less than 94, we got to start treating with oxygen. But false indicators, that's why pulse oximetry is a tool to go by. You can have a reading of 98%, but if they have high carbon monoxide levels in their system, it's still going to read 98%. What it's doing is it's reading molecules on the red blood cells, right? Traveling through hemoglobin, red blood cells traveling through the system. It's reading that, whatever's attached to it. Carbon monoxide attaches over oxygen on these cells. And it says, oh, well, it must be fine because there's something attached to it, even though it's not, right? So we're going to do CO readings instead. And we have something called rainbow cables that attach to our monitors. They give you CO readings as well. The hospital has them. Some fire departments have them on their trucks. It's called a RAD 57. Remember that before? No, you have. Remember the RAD 57 stuff. It's how you check carbon monoxide in the system. What they really need is a blood gas, which we cannot do in the field. They'll do an arterial blood gas and be able to get carbon monoxide readings and dioxide readings. But is the patient hypoxic? Yes or no? If they're blue, they're hypoxic. We got to fix it. Blue tint is bad. They want to be pink, warm, and dry. They are consider providing positive pressure ventilation, PPV, the fire terms. Okay, positive pressure ventilation for us is a BVM, forcing pressure. Okay, maybe you could put in fire terms, putting a vent fan into the window or the door frame, positively pressure in the house. We're going to do that with BVM in someone's airway. Right? We don't do negative pressure, only positive. Right? So we're going to ventilate the patient, 1 breath every 5 to 6 seconds for an adult. Breathe, breathe. As a brand new EMT, the first time you guys ventilate somebody, you're going to do this because you're nervous. And we're going to be like, slow down. Breathe and count to 5. All right, good. Overventilation is bad. It bypasses the trachea on the stomach. Stomach inflates, then vomit goes back up. If it's all over you, you don't want that. You want to be clean on your call, right? So slow your breathing down. We want to help a patient breathe, if they're breathing more than 28 breaths a minute or less than 8. Okay. If they're hyperventilating, we have to control that. If we don't control it, what happens when you hyperventilate? Pass out, right? Water rescue personnel in the room? Anybody? You went through it all? You've been through anybody else? Right? What's shallow water blackout? Hyperventilation is shallow water blackout. People can stay underwater for longer periods of time holding their breath if they hyperventilate. Right? You see that with your drawing a blank. You see that when you have your dives without equipment, without SCBA, your normal diving going down, they'll hyperventilate. But what's happening is they're building up too much carbon dioxide in their system. They're not ventilating appropriately. Therefore, you're trying to trigger your brain to not breathe like it's supposed to. You're taking too much carbon dioxide and causing you to pass out. That's shallow water blackout. In one of the classes for water rescue that I teach, there was a Navy SEAL that told lifeguards, hey, this is a case study that was there. I'm going to put myself underwater with a weight belt, 4 feet of water. Don't come get me because there's no need for it. I'm a Navy SEAL. I'm trained to do this and I'm practicing. So lifeguards left it alone and he put a weight belt on, hyperventilated to stay in the water for a long period of time. What happened? He blacked out. He drowned in 4 feet of water. The lifeguards didn't go help him because they said, what happened? What's wrong with this guy? Oh, he's a Navy SEAL. He's fine. Half an hour later, we have a dead Navy SEAL in 4 feet of water because he had shallow water blackout. He built up that carbon dioxide level in the system by hyperventilating, not being able to oxygenate appropriately, causing that. So hyperventilation will cause somebody to pass out. We have to fix that. How do we fix it? BVM to their face, and we ventilate every time they take a breath in and try to control that system. By doing so, we're giving them oxygen and bringing the respiratory rate down. Now, if it's less than 8, that's bad too, right? It could be an overdose, could be a brainstem issue, could be anything, right? Most likely it's an overdose. Again, don't stereotype anybody, but I'm still going to check, right? Ventilate, 1 breath as they breathe in, control their rate, bring it up to 12 to 20 breaths a minute. The goal for oxygenation is 94 to 99. Notice that we don't have 100, right? 100%, we don't want that. We don't want to put that and then above, right? Then we're over-oxygenating a patient. Right? We want to keep it between 94 and 99%. It's a good number to look for. And you'll see these numbers again on tests, by the way, too, 94 to 99. Now, again, if a patient says they're short of breath and have 98%, do not withhold oxygen from a patient that's short of breath. Okay? Observe how much effort is required in the patient to breathe. Do they have any retractions through here? Use of accessory muscles as well. Nasal flaring, you'll see a lot more of that with pediatrics. Okay? 2 to 3 word dyspnea, and that's something you document as well. If they can only get 2 or 3 words out, they're in respiratory distress in between breaths. Tripod position, so if you lean forward like this, kind of like you're sitting right now, like this, and they do this rocking like that because they can't catch their breath, and they're speaking in 2 words, and they're doing this. Remember that I told you guys all to do that on mine the other day? I don't know if anybody tried it or not. Maybe, maybe not. If you open your mouth and do, comes out really fast. If you do it again, it takes a little bit longer. That's creating positive and expiratory pressure, keeping your alveoli and your lungs open longer. Okay? That's a defense mechanism your body has to create PEEP. You'll see that in COPDers, right? Tripod, sniffing, labored breathing. For PEEP, positive and expiratory pressure. Yep. So our vocal cords and our trachea, our glottic opening here, okay, that helps create PEEP when we breathe, right? So we have normal PEEP, which is around 5, right? If we lose that ability, patients that have been intubated before and don't have the ability, it's still a little paralyzed inside, we have a harder time breathing. But with COPDers, they need that PEEP to keep that lung open to oxygenate. So there's something at the EMT level now that helps with that. And what do you think it is? Your thoughts? CPAP. The door closed. CPAP. CPAP stands for continuous positive airway pressure. Yep, except we have it for a mask we put on with oxygen going behind it, though, versus a regular CPAP device at home, which is room air, 21%. We want to provide that oxygen with it. And on top of that, we can also create PEEP. Now, CPAP at home also has PEEP as well. Usually people have it around 10 or so. We can go up as high as 20. Right. So a patient who is unresponsive or altered mental status, we do not want to put CPAP on because they can't control their own airway. The last thing you want is a patient who has CPAP mask strapped to the face and vomit into the mask, then you push it back into the airway. That's bad, right? But if they're alert oriented, but they're dipshnick and they can't breathe, CPAP. Keep in mind though with CPAP as well is that it's also can make someone claustrophobic. Now you're strapping something to their face. So a lot of times what I'll do is I'll hand it to them and say, you put it on your own face then. So they do, and they hold it up. They go, they start feeling better. And they're like, oh, this is working. Do you mind if I strap it on your head now? Sure. And then we put it on their head, right? Other things that work well too is having a medic on board for that too, and they can give like Ativan or some little bit of Versed for anxiety. They're going to bring their anxiety levels down. Respiratory distress, anything with respiratory distress, increased work of breathing, increased effort and rates, right? So our respiratory rates for an adult is 12 to 20. For a child, it's 15 to 30. And for an infant, it's 25 to 50. Those are our ranges. I'll say it again. Adult, 12 to 20. Child, 15 to 30. Infant, 25 to 50. Right? Those are our rates. And just because they're breathing between 12 and 20 a minute for an adult does not mean that their effort is accurate. Right? If they're breathing shallow, that's not good. If they're breathing irregular, it's not good. Right? We'll look at those. They all mean something. We'll cover that more in respiratory emergencies. Respiratory failure occurs when the blood is inadequately oxygenated or ventilation is inadequate to meeting the oxygen demands of the body. Then they're in failure. Right? These patients here probably need to be intubated at some point. They need more medicine than an EMT can handle. Now, they go out, they pass out, OPA, NPA, one or the other. OPA, if they have no gag reflex, if they do, put a nasal airway in, and we ventilate, and we just breathe for them, and keep that airway open. The ultimate result of respiratory failure, if it is not corrected, is death. All right? Circulation, mental status, pulse, skin color. Look at the skin, touch the skin, push on it, look for a cap refill. Check that circulation, right? If they're not being perfused, our brain will start to become altered. Our body requires 3 things to stay alive. Remember what they are? Oxygen, okay? What else? Blood. Blood. What else do we need to stay alive? Sugar. Sugar, blood, oxygen. Take one of those 3 away, you die. Fire triangle. Remove one of the 3, fire goes out. Okay? 3 things keep the body alive. Oxygen, blood, sugar. We're going to assess the pulse, right? Rule of thumb. This is street medicine now, okay? Not book stuff. If they have a radial pulse, okay, usually their blood pressure is around 90 systolic or higher. Okay. Now, can you have it at 80? Yeah, can. No radial, but a carotid pulse, give a blood pressure of at least 60 systolic. Rule of thumb, okay, this is not testing material. To find a radial pulse, write down the radial bone here, little gap in between, 2 fingers. Okay, do not use your thumb. Your thumb contains a pulse. You give you false reading. 2 fingers here. Now, with elderly patients, okay, you may have to manipulate their hand a little bit to get a pulse. Don't push too hard, then you occlude it. Okay, try it on yourself. Push hard on your radial. It goes away. Okay, loosen up a little bit. Find a radial. Count it. 3 things we look for in a pulse: rate, rhythm, quality. Okay, is it fast or slow, regular or irregular, bounding or soft? Okay, if it's fast, tachycardia. Slow is bradycardia. If it's irregular, could it be atrial fibrillation? Is it regular, then skips, then stops? Is there pauses? Good for us to know. Okay. Is it bounding? Do they have like a high blood pressure? Is it bounding pulse? All right. So palpate, feel. If you cannot palpate a pulse in an unresponsive patient, start CPR. And that's not a radial. Checking your carotid. Find the trachea, slide to the side into the groove, and feel for it. Okay. Do not check a patient's pulse by putting your hand over the top of their neck. It looks like you're strangling somebody. Bad PR stuff. Okay. Go to the side or the side, 2 fingers, and feel for a pulse. If you think you feel a pulse, you're not sure, or there is no pulse, start CPR. If you can guarantee me there is a pulse there, then do not do CPR. If you're not sure, then start compressions. You're better off doing compressions with somebody with a pulse than withholding it. All right, that's basic stuff you have to learn in American Heart Association CPR. Yeah, bounding. Yeah, bounding is the other one. If it's bounding, like boom, 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 like really like, yeah. Skin condition. Evaluate the skin temperature, moisture, cap refill. A normally functioning circulatory system perfuses the skin with oxygenated blood. Right. Patients that are diaphoretic and pale have poor circulation in stomach. There's something not being perfused. Could it be a cardiac condition with a blockage? Yep, it could be. Something is not being perfused somewhere. Or is it hypovolemic shock where we're losing blood or fluids? Can a patient go into hypovolemic shock without bleeding? Absolutely. How? What was that? Without bleeding. Without bleeding. Can they? What was that? Not so much. We got to lose it. Or fluids. Excessive vomiting to put you in hypovolemic shock. Excessive diarrhea puts you in hypovolemic shock because you're losing that fluid, right? Hypovolemic. Right, but body fluids and self, yeah. All right, so looking at pediatric assessment, pediatrics vomiting, remember, a pediatric, if you were to take, this here. So if you take a can of soda, about 500 mLs, right? A can of soda is about how much blood volume is inside a pediatric infant. Is a can of soda. That's it. For an adult, you take 3 2-liter bottles, lay them across here. That's how much blood volume you have in an adult. 6 liters. Right? Different, right? So a kid, infant, can go in hypovolemic shock faster than an adult because their blood volume is just not there. Right? So if they're excessive diarrhea, excessive vomiting, can put a pediatric in hypovolemic shock quickly. The problem is kids can compensate like no tomorrow. Right? With an adult, you'll see a progressive decline, the patient getting sick and dying. With a kid, they'll stay here. They'll compensate. Then eventually they say, stop it, it does this. Right? So you got to pick up on signs and symptoms. You got to do a good job of picking that stuff up. Right? Kids are scary. They're scary to deal with because we don't deal a lot with them. A majority of our calls are adults, right? That's why you take other classes to familiarize yourself with just pediatric programs like PAIRS, PEP. Even still, I've worked city EMS for a long time, and we saw less kids. Still, we saw more adults than kids. A lot of drunks, overdoses, but we don't see a lot of kid issues because kids aren't supposed to get sick. They're kids, right? We don't see a lot of that. You see more of the elderly, nursing home, overdoses, drunks, ETOH, things like that. Yeah, yeah, right. Yes. Yeah, and then your body will also reproduce that stuff as well. It produces more, the electrolytes in your red blood cells, where that comes from bone marrow, everything else. So, yep, like short of breath, a little bit of chest pain. Yep, yeah. She went out of prep, and maybe they took a little too much, and then she was fine after, right? Eventually. Yep, yep. So that can happen, but then they're fine. That's why they usually give like saltine crackers or they give snacks. Yeah, exactly. Yep. All right. So determine by the blood circulating through the vessels of this and the amount of and type of pigment that present in the skin. So let's talk African Americans. How can you tell if they're pale, cyanotic, mucous membranes? You got to pull the lips back, look underneath. Exactly. Yep. No pigment there at all. We can see cyanosis. You got to pull the lips back underneath the eyelids. Things like that. Poor circulation will cause the skin to appear pale, white, ashen, gray. Remember, we want pink, warm, and dry. We don't want ashen, gray, diaphoresis, cyanotic. We want to stay away from that stuff. When blood is not properly saturated with oxygen, it appears bluish, as you can see around the kid's face in this picture. Maybe. Right? I promise it's there. You'll see it around here. Okay, I'll start turning blue. Right? Blue baby, bad. We want pink baby. Okay. Skin temperature, normal skin temperature, be warm to the touch. Remember, 98.6 is normal. Abnormal skin temperatures are either hot, cool, cold, or clammy. Right? Cold is bad. Patients that are septic can become cold. It's called not hypothermic, cold sepsis. All right, so cold sepsis is really bad for the patient, which means the thermoregulators are no longer working appropriately. I've had patients that are septic at 91 degrees. That's bad. That's cold, right? So, or they could be febrile at like 103. Usually it starts up high temp, then it goes the other direction. You want to catch it before it goes the other direction. Skin moisture, skin dry is normal. Skin that is wet, moist, or excessively dry and hot suggests a problem. Now, if you're outside working and running, you're going to sweat. It's okay. Your body's thermal regulators in the system make you sweat to cool down. It's when you are not doing anything, like sitting here, all of a sudden you start pouring in sweat. Right? That's a problem. Could happen. But again, you need to ask questions. Cap refill, evaluated to assess the ability of the circulatory system to restore blood to the capillary system, which is linear skin all through everything. All right, so press on the patient's fingernail is one of them. I like doing it on the skin up here too as well. And remove the pressure. The nail bed should return to its normal pink color. Push here, let it go, it should come back. Yeah, just checking the skin, nail bed. Yep. Another one too, in assessing circulation as well, is also, in 2 seconds, is checking what they call skin turgor. So you take here and you pinch, and let it go, pinch and let it go. If it stays tenting, usually they're dehydrated. Now, on a 90-year-old woman, male, doesn't matter, right? The skin has been stretched out and used and abused for all those years, so it may not pop back like it's supposed to. It's okay. Stick out your tongue, or that. If it's pitted and white, usually it means dehydration. Okay, your tongue shouldn't be all pitted and white and just dry, right? So look at that too. I mean, I wouldn't go with skin turgor so much on the elderly, because a lot of times it stays there anyways. So, but like someone like my age or whatever, pinch, let it go. If it doesn't go back, I'm pretty dehydrated. Huh? No. That's great hydration to stay awake. No, I don't get those very often. Those are $7. That's why I only get like one every couple days. All right, so assess this, and control external bleeding in trauma patients. Should occur before addressing airway or breathing. If they're bleeding out, we got to stop that bleed. All right, bleeding from a large vein is characterized by a steady flow of blood coming out versus arterial, which is a spurting, like it'll shoot across the room. Right, so apply pressure, get that tourniquet on, and then move forward. Okay, the days of applying pressure, more bandaging, elevation, all that, pressure points, those are gone. If you can't control something with direct pressure right off the bat, tourniquet, go to the next step. Tourniquets are back, which is nice. Yeah. So hemostatic agents, like quick clot. We actually do carry that. It's within the scope of practice for New Hampshire and Maine EMTs, but not something they bring into the National Registry. So yeah, we do carry that though. Yep. We don't have the powder because it blows around. We have quick clot bandaging. We just stuff into the wound, then we put over it with pressure bandage. So here, direct pressure, and apply a tourniquet if direct pressure is not working, or obvious arterial hemorrhage of an extremity. Right? Major bleeding here in the neck. We don't put tourniquets around the neck. Bad things happen there, right? But again, so if you have a bleed down here, we don't tourniquet here, okay? High up in the arm, and we stop circulation. Same thing with the legs. High up into the thigh, tourniquet, and it stops bleeding going down, right? The tourniquets, I should probably say this, they're only used for extremity bleeding, okay? We don't put them around the necks. Bad things happen. Scan the body to identify injuries that must be managed or protected before a patient is transported. Right? Rapid scans, rapid trauma assessments should take no more than 60 to 90 seconds, head to toe. Find immediate life threats and treat them. Right? A broken ankle is not an immediate life threat. That can wait. Right? A broken arm is not an immediate life threat. That can wait. Femurs, pelvis, okay? Immediate life threats. Splint them, treat them, move forward. A lot of blood loss. We don't get them stabilized. Not a systematic or focused physical exam. Okay, this is head to toe rapid scan. Primary assessment assists in determining priority transport. These are going to be a status 1, status 2, status 3. All right. Status 1 patients are critical. Status 2, borderline critical patients. Status 3 are like green triage. Yes, EMT. Yep. So high priority patients include those of any of the following: unresponsive, poor general impression, difficulty breathing. Those are your status ones in your level. Okay, because there's not much you can do for treatments. You can assist with NEB, CPAP, things like that. But again, there's still a status 1 until you get ALS on board, where they can put more treatments on board with the patient. A status 1 can improve. They can go from a 1 to a 3. They can go from a 2 to a 3. They can get worse. They go from a 2 to a 1. Right? It's just your initial impression when you're going to start transporting. High priority patients as well would be uncontrolled bleeding, responsive to but unable to follow any commands, severe chest pain, pale skin or other signs of poor perfusion, any complicated childbirth like limb presentation, placenta previa, ruptial placenta, and other ones that would be severe complications with childbirth, severe pain in any area of the body. Okay, priority patients. Remember, the golden hour is the golden period, is the time for the injury to definitive care. That's not the back of the ambulance. That's to hospital that can take care of that patient. Golden hour. Aim to assess, stabilize, package, and begin transport in the appropriate facility within 10 minutes after arrival on scene. This is what they call the Platinum 10. Right. You'll see a lot of this in pre-hospital trauma life support programs too, which is another class you guys should all take outside of here. Pre-hospital trauma life support, PHTLS. It's like $250, but it's a good trauma course, really good trauma course. There's other ones for pediatrics as well you can take that are really good too, like PAIRS, PEP. I do. I can offer. There's not in this program, but the separate classes we do once in a while. Determine the priority of the patient care and transport. We talked about this. 10 to 20 minutes, Platinum 10. The golden hour, you have an hour from the time the incident happened to get a definitive care. So think about that in trauma patients as well. Even cardiac patients, time is muscle, right? So the more time, because remember, your heart cannot rejuvenate muscle. Once it's dead, it's dead. Okay, so we have to keep it oxygenated. By doing so, we have to get them to a cath lab, right? So paramedic on board, get into the hospital. They can start medicine to help with that. They have TNK, Plavix, heparin, all this other stuff they carry in an ER to start that process and help reperfusing. But really what they need is a cardiac catheterization, which is a stent placed to open up that artery. Right? The golden time frame between that is 90 minutes from time to balloon. Balloon means they go in and open it up. 90 minutes. Okay, so time is muscle. Muscle dies. Heart muscle, cardiac muscle does not come back. Right? Once it's dead, it's dead. It's called infarction. So we want to stop that from happening by perfusing. Perfusing is stents. So as you can see, time is muscle. It's important. Determined decision, transport decisions should be made at this point based upon patient's condition, ability of advanced care. You may call for a paramedic and not get one. Your closest ALS could be the hospital. Distance of transport, and then follow your local protocols. So I'm not going to go over the ones here. If you guys want to come work for Action Ambulance, at that point in time, my job as clinical will teach you that. Right? Know what your local protocols are within your service and what you can transport and your capabilities. That's how it works with those. History taking provides detail about the amount, provides detail about the chief complaint and the patient's signs and symptoms, including demographic information, date of the incident, age, gender, race, past medical history, and current health status. What's going on with the patient? So we're going to investigate the chief complaint by making introductions, make the patient feel comfortable, and obtain permission to treat. Hi, my name is Kevin. I'm here at the ambulance. I'm a paramedic. What brings us here today? You tell me. Okay. Do you mind if I take a look at you? Sure. Awesome. I gave my consent, right? We got informed consent. Refer to the patient as Mr., Ms., Mrs. using the patient's last name and ask open-ended questions. So how does your chest feel today? What makes it different from any other day for breathing problems? Well, I'm a little short of breath. Well, what's different from the other days? Do you use home oxygen? I do. Well, today is a lot worse because I have a hard time catching my breath, and it's different than yesterday. Okay, tell me more about it. Right now, I'm gathering more information. I'm making them give me information that I'm looking for. Have we been there before or something? No, not at all. Because now we're having direct contact with the patient, and we see those all the time around here. You know, we go to frequent flyers all the time. What was that? Yes, right, exactly. Yeah. um, it's not a bad idea to share information, but again, you're directly involved with that call, right? Now, I wouldn't go saying, well, we go to this residence all the time, we don't have a call there, and this one comes. No. If you get dispatched to the call, then you can talk about that call specifically. It does help when they're frequent patients because you know more about them, you know their name when you walk in, you know. Be careful what you give out, right? Um, what's pertinent to what's going on. That's it. As long as you stay within the realms of your EMT, like you're working on the ambulance that day and you show up, you focus on just what's going on. That's it. Now, does it help to have other knowledge about that patient? Absolutely, it does. But now I wouldn't go sharing with everybody else, you know. But if you guys are on the ambulance together, that's perfectly fine. You're talking about the patient you're dealing with. That's it. Now, if you know personal stuff about them, okay, that's stuff that they just need to be privy to. Okay. What's going to pertain to help treat this patient currently? The patient is unresponsive. Patient information and clues about the incident may be obtained from either family members, bystanders, someone who may have witnessed it, medical alert, other pertinent medical history documentation, right? Like med lists, medication you found around the home. Living conditions can kind of help a little bit with it. If you see a patient on the floor, unresponsive, and they have a needle next to them, and they're by the refrigerator, could they be a diabetic trying to, could they have taken their insulin and then passed out, not eaten enough? You know, look around. A lot of clues can help you determine how you're going to treat your patient. Right. Yep. So don't do this. Yeah, that's bad. People used to do that, with urine. Tastes sweet. It must be diabetic. You good? Well, that's antifreeze. you know. So here are some of our history-taking acronyms we need to be familiar with, mnemonics, as you say. OPQRST. You're going to use that, live by it, learn it, know it, memorize it, and know exactly what it does. Onset. When did it start? Did it come on suddenly, or has it been a gradual incline? Provocation or palliation. What makes it better or worse? Does exertion make your chest pain get worse? Does exertion make your shortness of breath get worse? Does sitting down make it worse than lying down versus sitting up? If I push on this, does it make it worse? Quality. What is the quality of pain like? Sharp, dull, pressure. What does it feel like? What does it make? Excuse me. Region or radiation. Does the pain or pressure radiate anywhere? To your arm, your jaw, your stomach, your back? right? Does the pain radiate? Severity. The books may say 1 to 10, 1 is still a pain. 0 to 10, 0 being no pain, 10 being the worst pain you ever felt in your life. Where does that severity sit? And then timing. How long has it been going on for? Well, I've had chest pain for the past 10 days. All right. So why did you call today? What makes it worse today than before? Right? Well, I've had chest pain for 3 months, but today I decided to call 911. Well, why today versus 3 months ago? Explain to me. I want to know why. What is different today? Right? Identify your pertinent negatives. Right? Are you currently having chest pain? Are you currently having shortness of breath? No. Why I had shortness of breath 3 days ago? I decided to call now. Okay, why? What made you decide to call now? I know it's kind of a crazy question, but why did you call today? Well, I didn't want to bother you guys overnight. You're not a bother. Please call anytime. All right. We just need to know why. Why now? What is different now than before? That helps you determine how you're going to treat your patient. The quality of pain, is it sharp, dull? Yeah, tight. What does the symptom feel like? All right. We're at 76 of 177. We'll kind of go. This is kind of really in depth today, so let's keep moving, and we'll take a break. Sample history, signs and symptoms, allergies, medications, pertinent past medical history, not just past medical history. Okay, I don't need to know that you had your leg operated on 35 years ago, right? That does not mean much for your fact you're having chest pain right now. Now, if you had an operation a month ago, and you're having chest pain and shortness of breath, okay, could have clotted, freed up, and caused a pulmonary embolus, probably, maybe, who knows? But 30 years ago for surgeries. But patient has abdominal pain, right lower quadrant. Why had my appendix out 20 years ago? Okay, now I know it's not appendicitis unless a new one grew back, which doesn't happen, right? Or you bought one off the black market somewhere. But yeah, the thing is, again, it's gone, so that's good to know. 30 years ago, right? But pertinent to what you are looking to get for information. Last oral intake. Okay? Did they eat dinner last night at a seafood restaurant? They're sick today. Important stuff to know. Events leading up to the illness or injury. What were you doing prior to this happening? Well, I was outside mowing the lawn. It's 100 degrees outside. I'm having chest pain. All right, so you were mowing the lawn, exertion, hot outside, potential dehydration, chest pain. Electrolytes could be off, causing the chest pain. Who knows? EKG shows nothing wrong. Look at that. It's a series of events of what happened, leading to why you called 911. Critical thinking and assessment is gathering and seeking facts. This is your interrogation. It's fun, right? Evaluating, considering what information means, what they tell you, what it means, what's going on. And then synthesizing, putting the information together to plan and see management and patient care. We take our vitals, our history taking, OPQRST. We do all this within 3 to 5 minutes. The next thing you know, we have a potential diagnosis. We're going to start treating that diagnosis. Hopefully you have it right. Okay. Can that diagnosis change? Absolutely. Right? Look at that as a reverse pyramid. Okay. You have all this up top here that comes down to your diagnosis. Here are all your signs and symptoms and treatments, and we're going to work with that to figure out what's wrong with the patient. We're going to do tests, exams, touchy-feely, stick people with glucometers, or say that's to get a glucometer reading. We're going to do a bunch of different stuff. We're going to assess it, rule this out, rule this out, rule that out, rule that out. Okay, this is what I think it's going to be. We do that in 5 minutes. We start a treatment plan. We go from there. Alcohol and drugs. Signs may be confusing, hidden, or disguised. Right? People that like to shoot up, that have a life outside of just shooting up, where do they usually do it? In places that they can't see on your body. What's a common place they use? Between the toes, we wear socks and shoes. Right? So if you see track marks, eventually that goes away because they've destroyed their veins. They go somewhere else. Right? You'll see them here, not necessarily down here, because if they wear long sleeve shirts, you're not going to see anything up here at all, right? So again, look at that. Right? Look for obvious signs of stuff. Okay. And people that shoot up a lot, get creative. Just saying. But be professional about your approach. Right? Do not judge the patient. Treat them, assess them. History gathered may be unreliable. Patients lie or don't tell you the full truth. Patients may deny having any problems at all. They actually do. Right? You got to gain their trust. Physical abuse or violence. Report all physical abuse or domestic violence to the appropriate authorities. We are mandated reporters. You have to report it. You and I are friends, Nick. And I call you up one night and go, I'm pretty depressed. I'm going to kill myself. You have to report that. You're a mandated reporter. Okay, so keep that in mind. As a licensed provider, you are mandated. Same thing with Maine too. You actually have to go through a class on that, mandated reporting, which is a separate class. Follow local protocols and do not accuse. Instead, immediately involve law enforcement. If you suspect child abuse, don't want the parent to say you are abusing your kid. No, bad idea, right? Don't ever do that. Get the kid to the hospital, make your report, let the nursing staff know or doctor know what you think is going on, but do not accuse a family of it, right? Bad things happen. Don't do that. Follow your protocols and report the appropriate authorities. If you suspect abuse and you walk up to their kid and say, well, why are you abusing your kid? They may say, get out of my house. And you have to leave. You can't stay, right? They have the right to refuse treatment. So go along with it, transport the kid, and then let the hospital know. Sexual history. Consider all female patients of childbearing age who report lower abdominal pain to be pregnant. Which means you have to ask them if they're sexually active, even if they're 13 years old. Still got to ask that question, right? Inquire about the urinary symptoms with male patients. There's a burn when it pees, when you pee, right? Could it be an STD? Could it be a UTI? Could be. Got to ask those questions. These are sensitive topics. When appropriate, ask all patients about potential for sexually transmitted diseases. Right? So you got to remember, you got to ask those questions appropriately. Okay. It may be difficult for you to ask that. So, say you're a 22-year-old male EMT, you got a 16-year-old female in the back of the truck, and you got to ask her, "Are you sexually active?" You have to ask those questions. But if you have a female EMT with you, maybe it's better to have the female in the back with them, even though it's your tech. Maybe swap out and let them be able to make that assessment. Okay, sometimes it's a little bit better. Or have another female in back with you. You got a female patient who is, let's say, 16-year-old again, potentially could be pregnant, and mom and dad are in the room. You think she's going to be honest with you? Probably not. Can you separate them from the family? You can, right? Ask them the question then separate. Do you have to tell the parents what they tell you? No. Right? Transport them to the hospital. Let the hospital staff figure it out from there. Right? But you got to get information. You don't know how to treat it if you don't. Other challenges, obviously, silence. Patients is extremely important. You got to listen to be patient with the patients that are there. Use a closed-ended question that requires simple yes or no. Do you have chest pain? Simple. Yes or no. Then go to your open-ended. Now can you describe it? Consider whether the silence is a clue to the patient's chief complaint. Maybe they don't want to answer that question. Is there potential you could be pregnant? And then kind of deter you to something else. Okay. Go with them. Right? But again, keep in the back of your head. They deterred you to different questioning. We put you on a different path. They possibly could be pregnant. They just don't want to tell you right now. And that'd be the appropriate place. Overly talkative. Reasons why patients may be overly talkative. Excessive caffeine consumption. Nervous. Ingestion of cocaine, crack, or methamphetamines. Those are always fun patients to deal with when they're all over the place, looking around like a moth flying around. It's like, hey, focus. We're going to talk here. Underlying psychological issues. Okay. You'll know it when you see it. You'll pick up on it. Right? Get them to focus on what's going on. Get the assessment and get them to go to the hospital. All right. If they are nervous, try to calm them down. Okay, get to the same level. Be professional. Don't overwhelm them with questions. Go one at a time. Just try to have a conversation. Get them to calm down. Once you hit that point and you guys are both at the even playing ground with each other, then ask them more questions from there to get them to calm down and earn their trust. If they have multiple symptoms, this is often true with older patients. They'll tell you one thing, and they say, "Oh, well, my knees have been bothering me for the last year, and I have an ingrown toenail over here." And they start telling you more and more and more. And it's like, let's go back to the chest pain. This is the important stuff. And if they have multiple, start with the most serious, and then end with the least serious. I understand your arthritis is bothering you, but you're having shortness of breath. Why don't we focus on that first, and we'll get to the arthritis. All right. Anxiety. Some anxious patients show signs of psychological shock, pallor, diaphoresis, shortness of breath, numbness in the hands and feet, carpal pedal spasms, anxiety, hyperventilation will cause that. Calm them down. Dizziness, lightheadedness, loss of consciousness. Okay, people that are over anxious will have this happen. However, it does not mean that it's anxiety. Multiple syncopal episodes, syncope being passing out, chest pain, restlessness. What could that be? What can cause all that? Not anxiety, even though there's signs and symptoms of anxiety. What else can cause all this? What do you think? Something cardiac, right? Pulmonary embolus. Clot forming in the, breaking into the lungs. Then you ask more questions. 22-year-old female. What other questions you want to ask her? What's an important one? What specific medication can cause clotting? Birth control. Are you on birth control? Yes. Okay, that can cause clotting. Something to think about. I bring that up because that happened to me one time with a patient. I was an intermediate. I called for a paramedic. I knew something was wrong. I had PE suspicion. The medic jumped in the truck, yelled at the patient, told her to calm down. You're being over dramatic. Roll it off his anxiety. Transported anyways with me to get to the hospital. The paramedic paints his picture. Didn't want to listen to me at all. I said, I think this is a PE. All the signs and symptoms are there. Well, it couldn't be. She's 22 years old. They didn't do any vitals on her, put her in the room, and they walked away. I stayed with her. A minute later, she coded. Cardiac arrest. I started CPR on her right away. Yelled out code. They came running in. Said, told you this wasn't anxiety. I was pissed. I was beyond upset. I was a patient advocate, and I stayed with her because I knew something was wrong. The choice words I had with that paramedic after the fact, I'm not going to repeat over recorded here. It was not pleasant. And I did go to his chief and report him because he did absolutely nothing to help her. Didn't even care. He did. And then he had to do the transfer afterwards for a stat transfer. They pulled a clot about this long out of her lungs. She coded twice in the ER. We got her back. She lived. She's perfectly fine now. Patient advocacy. Just because it's anxiety does not mean it's anxiety. Look at everything else in the factors and do your assessment. I was an intermediate in paramedic school, and I was with a burnt out paramedic who just didn't care. So keep that in mind. You are a patient advocate. Anger and hostility. Friends, family, bystanders may direct their anger and rage towards you because you are supposed to be the one there to help. Remain calm, reassuring, and gentle. Never tell a patient everything's going to be okay. Tell them we are doing the best we can to help you. That's truthful, right? Be careful of being reassuring. If the scene is not safe or secured, make it secured. Intoxication. Do not put intoxicated patients in a position where he or she feels threatened, because they will potentially fight back. Or they become, what is the word? What was that? Not combative, where they kind of hold everything in, no talk. They become closed. They close up on you. They shut down. Alcohol dulls patient senses as well. We do not sign off patients that are intoxicated. Okay? You need to contact medical control and talk to the physician on the consultation and see what happens. Right? We do not just put ourselves out there for risk like that. Potential for violence and physical confrontation is high. What was that? Yep, you can. But they can also be alert and oriented. Answering all your questions appropriately. Then, hey doc, this is what I got. He doesn't want to go to the hospital. He's alert and oriented, but he's highly intoxicated. Right? Let the doctor make that decision for you. Pass the buck to a higher level so it helps you out. Crying. A patient who cries may be sad. But they could also be in pain or emotionally overwhelmed. They're stressed out. They're having a breakdown. Remain calm, be patient, reassuring, and confident. And maintain a soft voice and have a conversation with them. Right? Try to bring down that anxiety level a little bit. Okay? They're crying for a reason. Why are you crying? Right? Depression, among the leading cause of disability worldwide. Okay? Symptoms include sadness, hopelessness, restlessness, irritability, sleeping and eating disorders, and decreased energy level. So be a listener. We're there to help them out. Listen to what they have to say. Okay? We are not psychologists. We're not psychiatrists. We're not there to determine what's wrong with them. There are people out there that can help with that. Get into a hospital and have them speak with a professional. Okay? If they're suicidal or homicidal, they're going to go to the hospital. There's no way around it. They have to go. They'll be assessed by a professional and a physician as well. And then they'll make the determination whether or not they get help or they get to go home. SI and HI stuff, they need to go. There's definitely something wrong if you have plans of killing other people. And ask them, do you have a plan? Maybe they'll tell you what the plan is. Maybe they have a list of people they want to get rid of. Right? Maybe they want to hurt themselves. Maybe they have a plan in place to do it. Or are they just doing that to get attention because they are depressed and need someone to talk to? Confusing behavior or history. Conditions such as hypoxia, stroke, diabetes, trauma, medications, and other drug could also alter a patient's explanation of events. May not be very accurate. Older patients could have dementia, delirium, or Alzheimer's as well. So again, looking at all this as a whole, what can you take as truthful, what can you not? And looking at, again, your sample history. Medications will paint a good medical history for you. Limited cognitive abilities. Keep your questions simple and limit the use of medical terms. Okay. Don't use big words. It confuses people. Use big words with doctors, nurses. Small words with people that have no idea what we do for a living. Right? Keep things simple. Abdominal versus stomach. Use stomach. Belly for kids. Be alert for partial answers and keep asking questions. And rely on the presence of family, caregivers, and friends for supply answers. Okay. Cultural challenges. Do not use medical language. Patients may prefer to speak with healthcare professionals, providers of the same gender. If you have the ability to do so, then do it. But if you don't, you can't request mutual aid in other towns, right? But do the best you can. Gain the assistance of the patient's friends or family members. If you can't get them to go, maybe their family members can, right? Even if they have to go personal vehicle, if they're that stable enough and they can take them by personal vehicle, then so be it. At least you're getting them to the hospital. Just call med control and run it by them. Enlist in the help of other healthcare providers. If you can't convince the patient to go, then call a doc, put them on speakerphone, have the doctor talk to the patient. Maybe they can convince them to go. Language barriers, find an interpreter if possible. Okay, not so much around here. Inner city stuff can be difficult, right? That's why I have the Translate apps on my phone, so I can talk into it and have it play it back. Makes it a little bit easier. Ask questions that are straightforward and brief. Okay, don't go into a whole spiel. Hand gestures help. appropriate hand gestures, please. All right, and be aware of language diversities in your community. Learn some simple sign language, simple ones that you can remember. Hearing problems, again, ask questions slowly and clearly, let them be able to read your lips. Pencil and paper work really well, or a dry erase board, and simple sign language. Visual impairments, identify yourself verbally when you enter the scene, because they may not be able to hear anything. Return any items that have been moved to their previous positions, so they know where something's put. You start messing with them inside the house, and they can't find stuff, you could put them in a bad situation. And explain to the patient what is happening each step of the vital signs assessment. I'm going to take your blood pressure. This is going to inflate on your arm, right? You're going to feel some pressure on your arm, then it's going to release. I'm going to place this probe thing on your finger. It's not going to hurt. You're just going to measure your oxygen levels. Let them know what's going on. All right. So now we're going to start our secondary assessment. Now that we finish our primary stuff, why don't we take our lunch break and come back? We're at 96 of 177. So this is probably one of the longest chapters we're going to cover. All right. Yeah, this is even worse. It may get to the point where I don't do airway today. And I bring that up in one of our next lectures. Let me just stop recording really quick.
This conference will now be recorded.
So your secondary assessment may be performed on scene in the back of the ambulance en route to the hospital or not at all. You may not even be able to hit your secondary depending on how bad the primary assessment is going, right? But your secondary assessment can be done on scene. Most of the time it's done in the back of the ambulance, like significant traumas. I like to see that with a rapid done before you transport. My own personal thoughts behind it. So that helps you identify better life threats really quickly with a rapid trauma. But this purpose is to perform a systematic physical examination of the patient head to toe, and you touch everything going down in 60 seconds. And then when you get in the back of the ambulance, then you can go more in depth on a head to toe and actually feel everything going down to see where other injuries you may have missed in your rapid you may find on your more of your detailed assessment with that. So again, head to toe is secondary assessment. So how I want to assess, we're going to inspect, palpate, auscultate. Okay, so we can't. So we're going to inspect first. We're going to look. We're going to touch as we're palpating. So touch, feel the patient abnormalities, palpating the abdomen, feeling the bones, moving bones around, manipulation to see if there's any crepitus. You need to go actually all the way through. And I'm going to show you guys a full head to toe assessment. We'll bring a stretcher out, have someone lay down. We'll use the power cot so we don't have to lift up and down. And we have to auscultate. So we're not going to auscultate a humerus, right? We're going to auscultate lung sounds, heart sounds, abdominal sounds. Is there any movement? These are where you use a stethoscope for. That's your auscultation, right? Inspection, look, palpation, touch. Right down through. We're going to use another mnemonic called DCAP BTLS. We just call it DCAP Beatles. Interesting, right? So we're going to compare findings on one side of the body compared with the other, if possible. DCAP BTLS is what it stands for. Deformities, contusions, abrasions, puncture, and penetration. I'm stopping there for the most of that. So, deformities, contusions, abrasions, puncture, penetration. There's your DCAP. You guys ready for the next part? Right? BTLS, burns, tenderness, lacerations, swelling. So, deformities, contusions, abrasions, puncture, penetrations, burns, tenderness, lacerations, swelling. That's DCAP BTLS. So, on your run report, you can put down, they're perfectly fine, negative DCAP BTLS. That's an approved mnemonic for a run report. So you don't have to write out the entire thing. It's just simple. Okay? Compare one side to the other. If you have knee pain, look at the other knee. Is this one more swollen than the other? How does it look? Compare each side. Right? Perfect. Systematically assess the patient's secondary assessment. The goal is to identify hidden injuries or identify causes missed during your 60 to 90-second exam during your primary. Right? So this is more of your detailed assessment. Like an older text, it was called detailed. Now it's secondary. Right? So we have our primary, rapid, detailed. Now, if we do not need to go into our detailed assessment, we can do what they call a focus assessment, which we'll cover on the next slide. So a focus assessment is performed on patients who have sustained non-significant MOIs or non-responsive medical patients. Yeah, okay, either way. I lost my train of thought for that. But if you have a patient, let's say they tripped and fell and they hurt their knee, okay? I'm not going to do a detailed assessment on their shoulders when all they are complaining of is knee pain. So we're going to do a focus assessment based on the knee itself. That makes sense? So focused on significant or particular body parts versus a detailed assessment, which we go down through head to toe to find more issues. All right, this is typically based on a chief complaint. So if I have ankle pain, I don't need to start assessing their elbow. Does this make any sense? Right? You know, I'm not going to palpate their chest and start touching them inappropriately like that when they don't need to be palpated. Like doing a 12 lead on the patient that has ankle pain. But why do you need to expose their chest for a 12 lead when there's no indication for it? That starts becoming creepy. All right, and people start saying, huh, why are they always doing 12 leads on 17-year-old females, but yet the 30-year-old doesn't get it? I pick that kind of stuff up when I'm doing clinicals, not here. I'm just saying I would pick that up doing CQI. Like, why does this always happen with this age range? That makes me wonder. And I say, come to my office, let's talk. So the goal is obviously to focus your attention on the body part or systems affected by the priority problems. Respiratory system. Expose the patient's chest, right? If you can take their shirt off, look at their chest. If they have a bra, do not take that off, please. Okay, leave it intact, all right? Unless you get permission. Do you mind if the bra comes off and I'll put a gown over you or something like that? But if there's no gown in the back of the ambulance, sometimes we carry them, sometimes we don't, then try to leave the bra intact, cover them up, okay? If you have to, just pull their shirt up, okay? Listen, look, inspect, palpate as needed, and put their shirt back down over them. There's no need to repeatedly look at somebody with their shirt off. Unless you have a significant trauma or something like that, where you got to monitor that, that's different, okay? Again, for the respiratory system, expose the patient's chest. We're going to look for signs of airway obstruction. We're going to inspect for symmetry. What we're looking for is hands around the chest, okay, underneath the breast for females, pectorals here for males, like this. Come take a deep breath. Spread your fingers apart. Allow for widespread area to be covered. Have them breathe in and out. So you can feel equal, rise and fall. As you're doing that, your fingers are also palpating the ribs, and if you feel an indentation, then potentially could be broken ribs there, okay? They'll sit, the rest of the cage will go up and down, right? That's what they call flail segment, 2 or more consecutive ribs broken is flail. So you'll be able to feel. Well, that's just your rise and fall. Then you can actually push and palpate afterwards. For your initial rise and fall, you're going to feel, make sure it's going up and down the same. If it doesn't, it does like this, maybe a paradoxical movement, that's bad, okay? We have potential for a lung being collapsed. We have significant trauma, broken ribs. We gotta look for that. We're gonna measure listen to lung sounds, right? And then we're gonna measure for respiratory rate. How fast are they breathing? Rate, rhythm, quality. How fast they're going, the depth, is it shallow? Is it inadequate breathing? Is the respiratory pattern different? And as you're doing, look for retractions and increased work of breathing, looking for muscle retractions to the chest walls and everything else. Normal ranges, we talked about this one here, 12 to 20. Children breathe at a faster rate, 15 to 30. Infant, 25 to 50. We're going to count the number of breaths in a 30-second period, and we're going to multiply by 2. If I were to measure someone's respiratory pattern or rate, if you tell somebody, just go ahead and breathe normal and measure your breathing pattern, they're not going to breathe normal for you. They're going to focus too much on it. So what I usually do is I take the back of my hand, I put it on their stomach, and then I check their pulse. So the other side, I'm checking your pulse. And what we're really doing is you're measuring your hand moving up and down. You trick them into it, right? Because once you start focusing on, when they start focusing on what you're doing, they may try to change their breathing pattern, and then things become different. And you're not going to get what you're looking for. You can do that too as well. You just got to be careful with that with respiratory because you might not catch the irregularity if there is one. Pulse rates are fine, 15 times 4. If you're not good at multiplying things by 4, then do it by 2. It's easier. Respiratory rhythm, regular. The time of one peak chest rise to the next is fairly consistent. So normal breathing, if they're going like that, okay, that's a different type of respiration, which we'll get into in respiratory symptoms. All right, you have Chainstos, Kussmaul's, respiratory patterns you're going to come in contact with, which we'll cover more in respiratory emergencies. The quality of breathing, obviously, is normal breathing is silent. Now, if we hear anything other than silence, then we have other issues, whether it could be rales, bronchi, wheezing. So we could have what they call pleural rubs, so it could be rubbing sound like this inside. You could have rales, which is like a fluid. And then rhonchi, which is like a junky, like mucus type sound. You could have wheezing, which is wheezing, right? We hear that. So a lot of different potential lung sounds we're going to have. The best way for me to teach you lung sounds is get a stethoscope, find a computer speaker, turn it down low, put your stethoscope over a computer speaker, and find lung sounds on a computer and play them. Because I can teach you them all day long listening through here, but you're not going to put your ear to their chest, which is weird. Okay? You're not going to cuddle with them, right? What you're going to do is put a stethoscope in and you're going to listen. Okay, right? So everybody should have a stethoscope. You have your own. Right. I carry my own in my bag. I was with me on all my calls. Like this. Right. So I bought a Cardiology 3. This is a $300 scope. Then I bought something called an Echo, EKO, with a $150 attachment down here. You turn it on, it multiplies the sound by 40 times. So if you have a hard time hearing, that's great. It also records to my phone, then I can upload it to my run report, the actual sounds. No. You can buy a cheap $30 scope and still buy this for 150 bucks, and it does the same thing. I had a Cardiology 3 prior to these even being invented, so I kept my scope. Then I bought a cover for it, but literally it's just a stethoscope with an attachment to the end. So the bell comes off of this, and you put this device in the middle. If not, this just stays on here. It has adult and pediatric. It just turns it, and then changes from adult to pediatric scope. So again, I'm not saying go out and spend $400 on a stethoscope. Get something that works for you. Okay. Some people don't like the. You have one behind you, right? But hold yours up for a minute. Amazon has them. All right. Do you notice how his has 2 different tubes? He may like that type of scope, and it may work really well for him. For me, those tubes rub together, and it creates too much noise for me. I don't like it. These here, all right, these scopes here come in double, and there's 2 chambers inside of this, but it's all one. So literally, it can bounce around like this, and you won't feel it. You'll hear a difference. And I just bought a protective covering for it. For one, little kids like seeing this kind of stuff. We deal with pediatrics. 2, it always sparks a talking point for me because I wear a Miami Dolphins in New England Patriots territory, which is great. I love having that discussion with them and ask them how their team did last year. But it's always fun though. Then it gets people, it kind of breaks the ice a little bit. Oh, you're a Dolphins fan? Yeah. How'd your Patriots do last year against them? Oh, that's right, they lost. But then they start laughing and they have a good time. And now we've built a good rapport and we're going to have a conversation. Hopefully they don't try to stab me later when I'm not looking at them. But again, why do you have tachycardia now? Oh, because you guys lost again. But so I utilize those kind of things like that. And then little kids, if you buy, like you work in a pediatric wing or something like that in a hospital, you can get ones with like stuffed animals on it, rainbow unicorns. No, you're not on ketamine for that. You're good. So different things like that. And also it protects the scope. So if things rub up against it, I'm not going to get lacerations in these tubing because, well, I don't want to spend another $300 on a stethoscope again, unless I have to. So yeah, like yours is a single. Yours is kind of like mine. You can take that buy one of these things here and amplify it by 40 times. You know, there's different methods of things out there. Look what works for you. I have this, get alcohol prep, clean it up. You guys can try that out today and take a listen. Okay, it's loud, so don't hit it. You won't miss it. All right, but yep. You can take this right off of here, okay, and have my phone on through Bluetooth and put that onto a patient. And I can put those headphones in, my AirPods, into this and use that, listen to lung sounds that without even putting them in my ears. There's so many different things out there now with technology. It's amazing. Depends on how much money you want to spend and how reliable it is. The good thing about that, if the battery dies, I can still use a regular stethoscope. You know? So it's simple. But breath sounds, lung sounds are so important because we are giving medication to patients to help them. If you give albuterol to a patient who is in pulmonary edema, you think it's wheezing, you can cause them to flash even more. You can drown them internally. They die. It's a medication that you can administer. Just saying. So knowing your lung sounds is very important. Practice them. Listen to them. Do the trick I told you. Go back and listen to them on a speaker. But listen to them through a scope because that's how you're going to hear them in a real life scenario. All right? Practice on each other. Listen. All right, there you go. There's my little soapbox. Huh? Yeah. So looking for the depth of breathing, amount of air in the patient exchanges depends on the rate and tidal volume. Breath sounds. You can almost hear breath sounds better from the patient's back. We should listen to the back. Just check here, 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 and here in the front. Then you go 1, 2, 3, 4, 5, 6 in the back. Don't go 1, 2, 3, 4, 5, 6. Now you're not comparing all the lobes. Remember, there's 5 lobes in the lungs, right between right and left. 1, 2, 3, 4, 5, 6. Check both sides, compare them, look for levels of fluid level in it. Listen for rhonchi, rales, rubbing, wheezing, stridor. Let me warm up here. I'll figure it away. Yeah. Yeah. There's some on there, and you also go to YouTube. Type in wheezing. Yeah. Yeah. So wheezing lung sounds. Bring it up. Find a speaker, put it over the top, and they can listen to someone's lungs. Don't make it too loud so you don't kill your eardrums, and listen to it through a scope. And that's how you're going to tell the difference. Not listening to it on a speaker out with your own ears. Because when you're going down the road in the back of an ambulance with all that road noise, you got to know how to differentiate road noise from actual lung sounds. All right. So take your scope, put them in. This is in my ears right now. Okay. Take your scope, put it over the top of the speaker, and then listen to the speaker itself. Right. Don't put your hand on top like this. Causes noise. 2 fingers on the scope or the lungs. So like this. So like that, over here, and listen. Have the patient take a deep breath in and out. I hate when physicians do this. Go ahead and take a deep breath. And they go like that. No. In and out. In, out, stop. In, out, stop. Listen to the full cycle, right? Doctors, they just go, okay. Then do your whole entire back in like 5 seconds. Like, you didn't even listen to my lungs at all, right? You suck at your job. Seriously, stop. Listen to my lung sounds. I want you, if I'm paying you guys, $10,000 to do a physical assessment of me, at least listen to my lungs the correct way, It drives me up the wall. I called the doctor out of that time one time. I said, listen to my lungs. Like, I have a hard time breathing right now, right? That's why I'm here to see you. I want to be fixed, all right? Give me meds. So respiratory systems, as you can see here. We listen on the front and on the back. Respiratory patients in respiratory distress do not want to lay flat. I'll tell you that right now. They do not want to lay flat. Sit them up, right? Nursing homes. Saw it all the time in a town I used to work for. Well, for a bit. We get called respiratory distress. We get there. Patient's on a nasal cannula at 4 liters a minute, and they're laying flat. You sit them up, and they go, I feel so much better. Imagine that. You sit somebody up, and they feel better. All right? It happened a lot. make them feel better. Sit them up, apply the right amount of oxygen. Don't put an under breather on at 4 liters. It's not designed for that. It's designed for higher, 8 to 15 liters per minute, or 10 to 15 is actually better than 1 to 6 is nasal cannula. There's different ranges we have based on percentage of oxygen that you're actually receiving based on the cannulation type device you're going to be administering. All right, so we talked about this a little bit here. What do you listen for? Normal breath sounds. These are clear, relatively quiet during inspiration and expiration. Storing respiration, storing breath sounds suggests an obstruction or narrowing of the lower airways. They start snoring. The wheezing breath sounds obviously suggests obstruction of the lower airways, so you have that wheezing, mucousy type restriction. Therefore, you need to get something to dilate. We have medications called albuterol duonebs to help with that. Crackles, or like a wet lung sound, which used to be called rails. Now they call it crackles now because people couldn't spell rails apparently. Or crackling sounds that may indicate fluid in the lungs. You won't find rails all over. You'll hear them down low working their way out. There's other methods, something called percussion sounds as well. You take your stethoscope and you just, like that, you listen. And if you hear that hollow versus that thud versus the hollow sound, you kind of measure fluid levels a little bit. It's not percussion treatment, not treatment, but that's something different. That's for cystic fibrosis. But you do like percussion sounds. So you pull the stethoscope in, you just tap, 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 listen for the sounds. Percussion treatment, a therapy, then you cup your hands and you pat the back of somebody like this for like 15 minutes. That helps break up the mucus for cystic fibrosis patients. So medic school, you'll learn that. You spend a lot of time with respiratory therapy, and then they make you do all the work. Bronchi is going to be your congestive breath sounds, may suggest presence of mucus in the lungs, pneumonia. You might find bronchi as well. And stride are often heard before listening with a stethoscope. You hear that coming in the room, that high-pitched sound you'll hear, which usually in the upper neck, upper part of the chest, right here. So stridor would indicate like an upper airway obstruction. And you have the seal bark sound, which is a group, you'll see that in younger kids. Usually actually right around this time of year. You get that warm, cold, they get that. We have kids in the room, kids. We have kids in that group. Yours is probably a little young. We'll get into it though. So you've had croup before? Yeah. You're like, oh God, a kid can't breathe, let's go outside. And you go outdoors and everything will be fine. Yeah. Yeah. It is. Then you get the kid outdoors and then they're perfectly fine. Morning. Lunch.
This conference will now be recorded.
All right, you all set with this side? Perfect. All right, so cardiovascular. Look for trauma to the chest or listen for breath sounds. Consider the pulse, respiratory rate, and blood pressure, and then pay attention to rate, rhythm, and quality. I think we've hit that enough already, right? Rate, rhythm, quality, you should be saying that in your sleep, like CSAT, BSI. Right? You need to make sure you assess those 3 because those are important assessment factors. Consider your findings when assessing the skin. If they're pale, cool, clammy, and diaphoretic, we have a circulatory issue somewhere, whether it be bleeding with shock or the fact that they're hypoxic, your heart is pissed off at you in some way, shape, or form, causing this to happen. So check and compare distal pulses. Does this feel the same as this? Do tibial, dorsal, pedal pulses feel the same too? Is there a lack of circulation going somewhere? Check all the different pulse locations. So where are the different pulse locations? We covered this in AMP. Where are they? Okay, you got radials. Okay, now you're benched. Who else we got? You're benched. No more talking. Huh? Okay, what else? Somebody else. Dorsal pedal. Yeah, what else? You're grabbing groins of femoral, carotid, which you got twice. I didn't mean to bench you. Sorry. You're getting all the answers. Um, that's fun though, isn't it? I'm just picking on you. Good. But you're still benched. Um, so consider auscultation for abnormal heart sounds. There's hard sounds out there. They're called S1, S2, S3, S4. I'm not going to quiz you on that. That is not your place to be assessing heart sounds. Sometimes they're very hard to get the different heart sounds down and memorized, and sometimes they're very hard to hear. Right. So my thing is if you have a person who is cardiac arrest and you're ready to call it, just they can just listen to the heart rate, like make sure it's hearing the beats or anything at all. Other than that, I'm not teaching you guys heart sounds. It's not part of the EMT curriculum anyway. So just said assess auscultation for abnormal. Just listen. If it feels like it's beating funny, that's all you need to know. Let's see. Pulse rates. Obviously, normal resting pulse rate for an adult is 60 to 100. All right. Anything less than 60 is considered bradycardia. Anything greater than 100 is considered tachycardia. Right. Preschoolers and school-age children from 2 to 10 years old, the normal ranges are 60 to 140. Infants and toddlers, 3 months to 2 years, is 100 to 190. That's normal range. All right. Infants up to 3 months of age, 85 to 205 is normal. Okay. So if you get an infant with a heart rate of 200, it's borderline tachy, but nothing to be overly concerned about, but still find out why it's high. Okay. But in an adult at 200, right, that's a problem. That's what we call SVT or VTAC or rapid AFib if it's irregular. And those need to be treated with a paramedic scope of practice. What? If you exercise, your heart rate's at 200, then there's something else cardiovascularly wrong with you. Your heart should never get to 200 beats a minute. Even with exercising, the highest I've ever seen is usually 140 to 160, and it's controlled with rest. But 200 though, that's high. Your heart's really pissed off at that point. And if it sustains at that, then we have to figure out a way to chemically cardio. So we end up giving medicine like adenosine. It actually stops your heart for 12 seconds. It's 12 seconds, right? It is one of the scariest moments ever when you see that go to a systole. Sure, you're gonna feel funny. Oh God, down they go, flatline, and then it's back again. It's like, ah. and hopefully it stays low that time. The younger the patient, the faster the heart rate. So I'm mentioning the 200. If you got a kid who's exercising more, which they should be exercising as a kid, and it's around 180, it's fine. You get an adult, someone who's 40 years old, the heart rate's 200. That's something to be concerned about. It shouldn't be that high. Yeah, I'm not saying that it can't happen, but it also, another thing too is it should come down. If it sustains at that kind of rate, that's a huge issue. Yeah, but hopefully when you stop, it goes down after a cool down period. Depending on the condition of the patient, as far as like how healthy they are, like avid runners, bikers, and things like that, your resting heart rate could be 40. I've seen that before, and that's okay. That's fine. That's normal for you because your heart is in that good a condition, doesn't have to pump very fast, right? But if I got somebody who's 80 years old, the heart rate's 40. Okay, do they need a pacemaker at this point? Is it something electrical that's making this not work? Are they taking too many beta blockers that's causing their heart rate to drop that low? That they're having syncopal episodes? That's good for him or her. Good for them. Good for them. Not for me. I hate running. So pulse quality. Describe a stronger than normal pulse as bounding, right? Or if it's weak, it's called weak or thready. Right? So with pulse rhythm, regular. The interval between each contraction should be the same. So when your ventricles depolarize, I mean the thud, okay? Every time you feel a beat, that's your ventricle depolarizing. That means your left ventricle is pumping blood through the body, okay? That should be going normal. If it goes like this, okay, and you have an irregular beat, then it's what they call atrial fibrillation. So it's not pumping effectively. Some patients live in that, but they're also going to be on blood thinners. Okay, and then they take a fall and strike their head. Now you got to ask, well, you on blood thinners? You have a irregular heart rate. Oh, I never had an irregular heart rate before. Well, you do now. And now we got to figure out why that's happening. New onset AFib can be dangerous. It has to be treated. So if the heart periodically has an early or late beat, it can be irregular, or if a pulse beat is missed. Who drinks caffeine in the room? Hands up. Okay. No? That's good. Believe it or not, caffeine is actually bad for you. And it can cause premature ventricular contractions in your heart. So anybody had an energy drink before? Right? You ever felt that thud in your chest once in a while? You got the poof like that. You ever felt that before with caffeine? No? Sometimes you will. And that's what they call a premature ventricular contraction. Your heart prematurely fires. Right? So people that drink caffeine on a regular basis, a lot of coffee, if I put you on a cardiac monitor, you're most likely going to have a PVC at least once a minute. Sometimes maybe once in a couple of minutes you'll see one. And it's okay. There's nothing wrong with those until you have 4 in a row. They call that runs of VTAC. Or you have 30 a minute. Eventually your heart's going to get pissed off enough that you're going to go into complete ventricular tachycardia. Right? Those are the ones that need to get treated if they're symptomatic. Right? And the other one, are they perfusing or not? So on the cardiac monitor, we hold our pulses like this. We check. And then you see a PVC, and if there was no beat, then it's a non-perfusing. So interesting stuff, a little more ALS. But again, is it regular? And sometimes those PVCs can make it seem irregular, but really it's only a premature contraction. Yes. Yep. Adderall. Right. Yep. It also has cardiac effects. It could. It also has been causing tachycardia in people as well. Like Adderall was one of them. It would cause more of a rapid heart rate. And it was actually causing heart attacks in people as well. I'm not familiar with all of them. There's so many meds that are out there. But again, it's knowing how it reacts to your body. Some people take Adderall and they're perfectly fine. People take Ritalin, they're perfectly fine. Some others have bad reactions to them. Right? But Adderall had a study done there finding a lot of kids that were taking it were having more cardiac events. So it's also good to read studies too. If you get a chance to read medical studies like that, it helps you. Especially when you start getting all these new adjunct medications on TV. Here are the side effects. Up in death. It's like, holy crap. So read up on it, because you know what? New meds are out, and they're going to start putting these patients on them, right? So now you'll know a little bit more about them, more of the common stuff. All right, so blood pressure. Pressure of circulating blood against the walls and arteries, right? Systolic blood pressure is pressure in motion, right? Under pressure. And then diastolic is your arteries at rest. Okay, you have to have a resting period. So if your systolic blood pressure is 180, your diastolic pressure is 110, your arteries are not really getting much rest, and your body can only sustain that for so long before something bursts. Usually it's up here. You have a hemorrhagic stroke because your blood pressure is so high. You can stroke out. Dangerous stuff, right? Yeah, a small bleed.
Yeah.
Did they say where it was? Yep. Eventually that will go away. That's the plan behind it. Yep. You know what else causes that? Stress, hypertension, untreated blood pressure untreated blood pressures. So when you do vitals on an elderly female, sometimes or male, on a patient, I should say, and you have high blood pressure, you on medication, no, I don't take meds. You probably should, and try to convince them. That's what community paramedicine comes into play, is helping out with people. So a drop in blood pressure may indicate a loss of blood or fluid components. So again, diarrhea, vomiting, bleeding. A loss of vascular tone and sufficient arterial constriction. So widespread vasodilation, which you would see in sepsis. Bacteremia can cause widespread vasodilation, causing low blood pressures. So patients that have infection can do that. So it's a massive systemic infection that gets into the blood called bacteremia. So you got to pay attention to that. Cardiac pumping problem. So electrical conduction, if it's not pumping appropriately, can cause lower blood pressures. So there's a lot of different things cardiac-wise. We got to be able to be proficient in trying to figure this stuff out in the field. Decreased blood pressure can also be a late sign of shock. Okay, septic shock, hypovolemic shock, neurogenic shock can cause that kind of stuff as well. Abnormally high blood pressure may result in rupture or other critical damage in the arterial system and bleeds. Blood pressure cuff with a gauge contains the following components. There's a wider outer cuff, an inflatable wide bladder, which is inside of it, a ball pump, and a one-way valve, so you squeeze. Let me have a blood pressure cuff on it right in a second. I gotta get one on. All right. All right. It's up to you. For the class, it's not a bad thing. All the ambulances have them. We also have them built into the machines. But you got to practice. Blood pressure cuff, otherwise known as a sphygmomanometer. Right, BP cuff. We did. Okay. So this is very important, especially where it says place artery between here. You see these two lines? So it has to go over the artery. That's better. All right. On the back side, there's a range to see if it actually fits your arm. This will not fit my arm. Guaranteed it will not fit. All right. Come here. So let's put it on. What you want to do is when you put this on here, that white line that you see on your blood pressure cuff or the arrow has to be between that range in order for it to fit appropriately and get an accurate blood pressure. Right. So for you, okay, turn your arm right over. Locate the artery, the antecubital artery here, or not vein, but sorry, the radial artery. All right. So left arm here, right arm here. So I'm on the left arm. That goes over that. We're gonna wrap around, and you notice on her arm, it's fitting the range. Here, so it's fitting between. Right. What we're gonna do is we're gonna take the ball. Make sure you can pump it up. One side releases it. The other side goes tighter. Okay. As you're pumping, a rule of thumb for adults, I bet it's 200. Now, if I see the needle doing this at 200, okay, then I need to go higher. But a rule of thumb usually is 200. All right. And then as we go down slow. You need your stethoscope. So I'll put that on. I'll just take your blood pressure for you. Good boy, it's loud. Take the stethoscope. You place it just underneath the cuff. Like that. 2 fingers. This causes a lot of noise. All right. Let's try it amplified. You inflate. Go to 200. You slowly go down until you start hearing a beat. Your blood pressure actually is high. 160 over 100.
It's just
Sorry, I
your
make you
presence.
nervous. I
It's
know.
just your presence.
All right. So when you start seeing it move, that's not when the systolic blood pressure is at. It's not accurate at that point. It's when you hear it. Okay. And then when the beat goes away, that's your diastolic pressure. So hers is 160 over 100. Right? If you do not, for some reason, have a blood pressure or a stethoscope with you, you do something called palpation. So you can inflate it up like this. I'm going to put this on. That's it. Find a radial. Do it back. Find a radial pulse. Okay. Yeah. There. All right. You inflate the cuff so you can't feel it anymore. And when you start feeling the radial pulse again, so right about there, we're on 156. Okay. That's all you need to know at that point. So you know her systolic blood pressure is 156 over P, over palpation. You cannot get a diastolic number unless you actually have a stethoscope present on the arm. Okay. That's it. She has 155, or 156 systolic. Right. You can only feel the systolic blood pressure. Right. So you need something. Yeah. Try to put that on me for a minute. You can see the difference.
Oh, I know it won't fit you.
I want to show them though. So she's with my right arm. Yeah. So if you notice on my arm here, she'll try putting it on.
Try and get the sleeve out of the way if you can.
Yeah, don't put it over his shirts. You won't be able to get a good reading. All right. Yep. See how it doesn't even match at all? Okay. So it's not fitting. So either we're going to get an inaccurate blood pressure, or when you inflate it,
It's going to explode off.
right, this may come off. This is a newer cuff, so the Velcro is still pretty good. You can, but you have to get a by palp only though.
There have been cases where people have had double
Oh God, that's really tight.
They say, oh, they always take
Well,
my,
the patient went over 300 on my arm. That's good.
they always take my blood pressure down to my ankle.
So these here are designed to take it on the forearm, so you can put it down like this. So a lot of times you have like elderly that have a lot of pain and blood pressure and things like that, which happens. You'll just put it on their forearm and just run an automatic BP on them. The elderly patients have done that before, especially ones that don't have cuffs that fit their arms. You may have to use a child cuff on really frail elderly patients. But they make BP cuffs in all different shapes, and not shapes, different sizes. There's one for thighs. Nope, they have different ones because they're different bladders inside of them. So like on the cardiac monitors, we have a thigh cuff, a large adult cuff, an adult cuff, child cuff, pediatric, neonate. Neonate ones, some of them they'll fit on my pinky.
Yeah, toe cuffs.
Yeah, they're like that small.
Yeah, toe cuffs.
Yeah. Well, because you don't want to take a blood pressure on anybody that had mastectomies done because of the surgeries they had done with the arteries inside. You don't want to put any pressure. It's like someone that has a fistula in place for dialysis. You never put it over a fistula because you can dislodge it. Then they have to go back and have a surgical repair for that. Strokes, opposite arm of a stroke. You may not have the correct reading as well. So your pressure gauges on those, if you tell me patient's blood pressure at 155 over 75, I'm going to tell you that's wrong because it only goes in 2 increments. So it has to be 156 or 154. There's no 155 marked on there. And some people do that kind of stuff because they don't know what they're listening for and they make things up. So a lot of times, even in testing stations, like all my guys that we're doing your testing here will know their blood pressures. So if you tell me the blood pressure is like 40 points off, like you didn't do it right. You guess it. So take it again until we get it right. Because I want you, because this is important stuff. You're assisting with a medication called nitroglycerin, and if you make up someone's blood pressure, and you give it to them, and you tank their pressure to the point where they can't return, you're going to kill somebody. And that's on you. I don't know if they do or not. You know what? Amazon has everything. Just check it out. So I have, I have the AirPod Maxes here I can use, I guess, and I can put Bluetooth into my phone to this. I never tried it before, but I guess it could work. Let's see. So auscultation is the most common means of blood pressure. We shouldn't be getting automatic BPs on everybody first. Okay, it should be a manual first, so that there your ears don't lie. Those machines artifact can change a lot. Bumps in the road, things like that. Palpation method does not depend on the ability to hear sounds. You check it by pelt. What is that? We check them before your testing stations. It does, but before we do a testing station, we actually check the patient's blood pressures first. So we have write them down so we know what they are to make sure you guys are actually getting it. Now, if it's within like 10 points, we give it to you. But if you tell me if a person's blood pressure is 180 over 100, and we just checked it 5 minutes ago and it was 122 over 82, we gotta work on that a little bit. So here's your blood pressure ranges. Hypotension, blood pressure is lower than normal. Hypertension, blood pressure is higher than normal. So we got to look at those. These are your numbers up here on the screen. You guys want to see those, write them down. It's up to you. You can take up here with your phone and take a screen picture of it. Sometimes it helps a little bit too. Yep. It's on the online stuff. It's on here. You also have the same presentation on your stuff. It's called the comprehensive slideshow. This is it. You have access to everything that I do for the most part, other than everybody else's grades. Absolutely. Will you go back, Sandra? Yeah. Be very careful with EMS initiated non-transports, because you're putting yourself at risk. Right? Always offer a transport. And I'm not speaking about that as an administrator working for a company to make money. If you tell them no, you don't need to go, and they turn around and say, oh well, they told me not to go, and they died 2 hours later. So always offer the transport, and see if they want to go. The only time that they have said to us not to transport is with COVID now. They say if they're asymptomatic and don't have any respiratory compromise, they'd prefer us not transporting them, so try to inform what they need to do at home. But that was a state directive that came out from the state EMS office, so we follow those. Otherwise, I would say even if you want to go, we'll take you, but the hospitals can't do anything for you unless you actually have symptoms. A fever is not a symptom for transport. There's some Pedialyte, get some rest, take some Tylenol and ibuprofen every 6 hours, rotate them, 1,000, 600, 400, 1,000, 400. Rotate every 6 hours, right? And then make sure you drink Pedialyte, something with electrolytes in it, Gatorade mixed with water, whatever, and stay home. Now, the SpO2 is 88%. Now we have respiratory compromise. Let's bring you to the hospital to get treated. And that's what they were telling us to do. And Maine was the same way. Stop transporting all these COVID patients. We don't have any room for them. So if they want to go, but we try to convince them not to. Right. But you can always call med control as well. And then that's when you start having the conversations and do consultation. So a neurologic assessment should be performed with any patient who has changes in mental status, a possible head injury, stupor, syncope, dizziness, or drowsiness. Like 80 to, like 70 to 100 is not bad for diastolic. Anything over 100s for adult, for the adult. Anything over 100 is we don't want to have that. In firefighting, by NFPA standards, firefighter rehab, the number is 180 over 110. Anything over that, after coming out of a fire, we have to bench them and sit them for a while. And if it maintains that, they have to go to the hospital. We call it NFPA. So. Other things, evaluate the level of consciousness and orientation using the AVPU scale. Then we have to use our Glasgow Coma scale, which we talked about already, right? The lowest score you can get is a 3. That's a dead person. This table has a GCS of 3. The highest you can get is 15. That's perfect eye verbal motor. 4, 5, and 6 equals 15. Or 0. No idea. Mr. Glasgow probably made it that way. 0 somewhere. All right. Pupillary response. Very important. The pupil is the black center portion of the eye, the black part of the eye. Those are normally round and approximately equal in size. Deviation could be something neurological, with a head injury. They're both pinpoint. They could be an opiate overdose, most likely an opiate overdose. There's not much other really have issues with pinpoint pupils. Dilated pupils are a little bit different. There's a lot of other things that can cause that, including who's hazmat trained in here? Organophosphate, remember sludge or sludgeum, dumbbells at all. So the M in that is meiosis, which is dilated pupils. So you'll see that as well if you have a person that has a organophosphate poisoning, which is all hazmat. So in the absence of any light, the pupils will become fully relaxed and dilated. And with light, they become more constricted. So you just check the pupils with the light. I don't always carry a pen light, so I always have my phone on me though. So I just turn my light on like this, and I come to the side and go like this. And I look for their eyes to get bigger and smaller. I want good reactivity. The acronym we use for that is called PERLA, P-E-R-R-L-A, which is pupils equal, round, and reactive to light and accommodation. You also might see it in your book as PEARL, P-E-A-R-L. It's the same thing. Pupils equal, round, and reactive to light. Check that on all your patients, because you never know what you might miss. Unequal pupils could be a stroke, and it looks something like this. Patients do not normally have constricted pupils. Usually 99% of the time, it's some type of opiate in their system. Whether it be, even if they're taking prescription, like they're supposed to, they're probably going to get pinpointed pupils, right? So there are ways, so do not lie to me. I will find out what you are taking. Because I can tell by vital signs and everything else, you're on some form of drug. And if you have pinpoint pupils and you're a little altered and your respiratory drive is a little low, it's an opiate. That's the classic triad of the 3 things that causes opiate overdose. Dilated pupils could be a lot of things. Epinephrine can cause this, right? Everything is bigger. Dilation, right? So unequal pupils, as you can see here, could be signs of a stroke. Yep. Hallucinogenics can do that. So tell me, give me one natural hallucinogenic that you can buy in any store. And you have to snort it. Ready for this one here, though? Ready? You guys know what it is at all? Have you ever heard of it before? Nutmeg. Nutmeg is a natural hallucinogenic if you snort it. I'm not saying try that when you get home. All right. But again, it's a natural. I don't want to snort nutmeg anyways. God must burn. If they don't know about it, they don't know about it though. Mucinex DM. The DM in Mucinex can get you high. It is now. It never used to be. You know how many overdoses I went to for Mucinex DM? People were spacing out because of that. In Wolfboro, we had a bad round of acid go through a local school, which I cannot mention the name of in a recorded session. Saw a lot of acid overdoses and bad trips for a while. To the point where actually, yep, which I actually got them to tell me where their dealer was because I convinced them to tell me. It's amazing what you got, people. All right. The overdose, they overdose on it, and that the DM part of it, that's from Mucinex DM. And that if you take enough of that, it can make you get high. I know there's stuff here because I read about it, and I've had patients that have done it. Small number of the population exhibit anoscoria, it's called, which is unequal pupils. I know some people, one's that actually a medic that works in Sanford that has this. He has the anoscoria. And I loved, before when I was teaching EMT classes in Maine, I loved using him as a patient because it freaked out a lot of the students. It was great. So causes of depression and brain function as well, injury to the brain, brain stem, trauma, stroke, brain tumors, drugs, toxins, inadequate oxygenation, perfusion. All this stuff can have a reaction to the pupils itself. Talked about PEARL, P-E-A-R-R-L-A. The combination could be added into that, but it's the same thing I just told you though. All right. Let's see, neurovascular status, check for bilateral muscle strength and weakness. So we're doing what they call a Cincinnati stroke scale. That's also part of this as well. So we want to have a grip the same. Never use 3 fingers and have them grip. Okay. So try it on each other. Try 3 finger versus 2. Okay. 2 finger. Squeeze as hard as you can. You don't hurt. Doesn't hurt at all, huh? No, Lilies. Now squeeze as hard as you can. Feel the difference in pressure in the middle finger. Okay. So what? And it doesn't hurt as bad. You give me your 3 fingers, let me squeeze as hard as I can for you. What am I going to do? I'm going to crush your middle finger, right? Give me 2 and I'll squeeze as hard as I can and it won't even put any pressure. Okay? That's not going to hurt. This is going to break my finger, right? So 2 fingers versus 3 when you check. And also with 2 fingers like this as well, you can pull away and they won't let go. And if they're altered, they may not let go. Especially the elderly, man, they have death grips. It's crazy, right? But you got to be ready for that. But you want to make sure they're equal. If one's not as equal as the other, one's more weak. Okay, we have deficit on the opposite side of the brain. So if it's right side, something on the left side is going on. Remember, it runs opposite. Okay, so they're gripping like this, and one's like loose, one's really tight. Okay, that's bad. We know there's unequal grips. We're going to check for what they call pronator drifts. Arms up like this, close your eyes, and you'll see if one arm starts drifting. That's called arm drift. Have them smile. If one stays down, it's facial drift, right? That's a stroke scale. So Cincinnati stroke scale is slurred speech, pronator drift, and facial droop. Let's think of the other scales that are out there. There's Cincinnati, there's FAST ED, there's LA stroke scale, NIH stroke scale. There's all these different ones. I use the NIH stroke scale a lot because that's what the hospitals use. But FAST ED is what EMS has gone to now. And there's an app for that you have to get on your phone. It's called Join Triage. It's free. So I keep a medical folder right in the front, right? Join Triage. There it is. I put down, try it out. Yeah, I accept the terms. I start my scale. Is the patient on blood thinners? Yes. When was the patient last seen normal? You put in your time. Today at 2:21 p.m. Right? Does the patient have any facial weakness? Yeah, it's abnormal. Sure. Does the patient have any arm weakness? Yeah, moderate to severe. Check the speech content. Ask the patient to name 3 common items. Ask them that. Nope, abnormal. Tell them to show me 2 fingers. They can't do that? No, that's horrible. The patient have any gaze or deviation, which means their eyes deviate to one side or the other. Okay, they're like they're looking in one way and that's it. Yep, forced deviation, that's bad. They have a stroke scale of 7. Okay, large vessel occlusion probability, 60 to 85% large vessel occlusion in the brain. What's closest centers? There you go. Now we transport to the called JOIN, JOIN triage. The other app to get, and it costs like $10, is the PPP app, Paramedic Protocol Provider. If you're going to work in multiple states, I recommend getting that because it has all the different state protocols you can download to one app. I use this for Maine, New Hampshire, and Mass. So if I'm in Mass for the day, update. I'll click on Mass, leave it on my phone, and it stays underneath the Mass protocols. If I'm in New Hampshire, then in New Hampshire. If I'm working in Maine, I leave it on Maine. But it's called Paramedic Protocol Provider, but it's the state protocols. And it does the updates. I'm doing one now for Maine and New Hampshire because I'm just lazy to do it. All right, so moving forward. Huh? We have protocol books. You've been around, how long have you been in EMS for now? Around the job for? Right. Right. So you remember the old books, flip books we had? Yep. We used to get flip books we had to carry with us in our pockets at all times. Now they're all phones. So we do carry them on the truck, so we've actually photocopied them in binders as well. They're in the truck somewhere. We just don't use them. We have them on our phones. Yep. So check for complete thorough sensory assessment. Does this feel different than this? Okay. Sensory assessments. Does this feel sharp or dull? And you see end of your pen on a pen on there in a second. But does this feel sharp or does it feel dull inside of your pen? You know, so check for sensory. Test for pain sensations, position, and compare distal and proximal sensory motor responses from one side to the other. Right? Check the foot. Rub your finger up and down their foot. See if they can feel it. Is it tickle or not? You know, do they have any movement? Pinch it, you know, like that. See if anything's different from one side to the other. Check for sensory movement. Neurological assessment. Anatomic regions, head, neck, and cervical spine. You want to palpate the scalp and the skull. So you go like this, you palpate all the way down. All right, I'll do that again for you guys too. I'll run down through this and I'll do it in visual with you guys as well. Check the patient's eyes. Look at the color of the sclera, the white part, right? Because if it's yellow, what does that mean? Jaundice, which means what? Right, the liver is failing somehow, some way. Okay, so we're not gonna fix that, but it's good to know. Okay. Check the patient's cheekbones, then obviously the patient's ears, nose for fluid. What fluid are we looking for? CSF, right? Which would be yellow or clear or pink, purple, clear, right? And it mixes with blood as well. So how do you check and see if it's CSF inside of it? Was that? Yep. Okay. Yep. The ring. Yep. With the gauze, and it puts a yellow ring around it. That's CSF, but it separates from the blood. Now, I'm not saying that you guys need to check or anything. Hold on, guys. I know you're bleeding out. Okay. Get it later. Treat the patient. Okay. And work with it from there. Check the the maxilla, the mandible. Check the jaw. Feel right down through. Palpate the neck. Right here. Check for tracheal deviation, side to side. Check for any jugular vein distension on the necks, the side of the neck. JVD means there's a backup somewhere, usually in like a pericardial tamponade or something like that, some kind of pressure on the heart will cause that to back up and cause neck vein distension. Tracheal deviation is a late sign of a tension pneumothorax or collapsed lung. But eventually what will happen is your trachea will actually deviate and pull to the side of the lung that's actually working. Weird, huh? Right. It pulls to the side that works. Okay. Late sign. You should be able to pick it up without your lung sounds right out the bat, though. Any unusual odors in the mouth? I'm not saying get your nose inside the mouth and start sniffing. All right. If you smell a fruity smell, it does not mean they drank alcoholic beverages that have fruity taste to them. What else could that mean? Sugar what? Is up high, or what does that actually, we haven't even covered endocrine yet, but I want to see if anybody knows this. What would give off that fruity smell? Yes. But what's that? What is that smell you're smelling? The release of what? You're on the right track. You're on the right path with it. But what is that smell? It is diabetic ketoacidosis, but what's the smell you're smelling? The release of ketones. Sorry, ketoacidosis. So you're releasing the ketones, which is that fruity smell. And that got cops in a lot of trouble because they were arresting people thinking they were intoxicated. In real reality, their blood sugar was 500, and they were releasing ketones that smelled like a fruity drink. And they were taking them to jail, and then they were dying. So now when we get called, evaluated for PD for intoxication, we have to check a blood sugar before they can take them into custody. And if it's high, then it's DKA. We got to transport them to the hospital. If it's normal and it's just alcohol, PC they go, right? So check blood sugars. Any patient's mouth looking for broken teeth, missing teeth, note that they're broken. Right? Make sure they're not in their airway as well. Look for the chest, visualize, inspect, and palpate. Watch for both sides of the chest rise and fall, and observe abnormal breathing signs. Right, moving on. Abdomen, we're going to check all 4 quadrants, right upper, right lower, left upper, left lower. We're going to palpate for tenderness, rigidity, and patient guarding. If they're guarding, if it's very rigid, and I'm not talking about someone that has abs. It's like solid, like rock solid, like you can feel that there's blood pooling underneath it. Okay, it's very rigid, hard abdomen. Right, that's bad. Okay, we talk about rigidity. Tenderness, rebound tenderness. They push down and come back up in an extreme pain. You'll see that like an acute appendicitis. Looking at McBurney's point, where I mentioned before, the right lower quadrant. You palpate, push down on that, and rebound tenderness coming back up. And then document that. I felt we have rebound tenderness and pain noted. Feels like a sharp stabbing pain in the right lower quadrant. You know, patient still has their appendix. They have a fever, possible appendicitis. Last thing we want is that appendix will rupture. If it ruptures, they're screwed. They need immediate surgery. The pelvis, we're going to inspect for symmetry and obvious signs of injury, bleeding, or deformity. We're going to push into the pelvis, and we're going to rotate in and back. Okay, don't rock a pelvis like that. The severed arteries, people bleed out, bad things happen. Extremities, inspect for asymmetry, cuts, bruises, swelling, obvious injuries, and bleeding. DCAP, BTLS. Check for pulses, motor, and sensory. They used to call it PMS, pulse, motor, sensory, right? It's a bad thing to do when you're telling a female, I'm going to check your PMS right now. They switched that to CSM, sensory motor, or sorry, circulation, sensory motor now. So checking CSMs, not PMS. Careful how you're wording stuff. Posterior body as well, looking at the back, inspect for DCAP BTLS, again, open wounds, and palpate from the spine, from the neck to the pelvis. So really start up here, and you work your way. It's not a quick rundown. Palpate each spinal process, every bump. You're feeling for it if it's stepped off or not. It doesn't stop here. It literally goes into the butt crack. So you got to go right down to the crack, okay? Right down. Feel everything going down. If anything's off, you got to note that region that it is. I'm not saying you have to know it's T12, T11, T10, right? But thoracic region, I feel some step-offs. All right, good. An X-ray will tell you exactly where it is. Assessing vital signs, use appropriate monitoring devices like a pulse oximeter. It is a tool. It is not definitive. Definitive is what you can see, hear, and feel, right? If it says 100% and they are turning blue, I would be safe to assume that your pulse ox is not working appropriately, right? Or their oxygen levels are really just that low and they have pretty significant carbon monoxide poisoning. Remember what I mentioned about tools? All they are is a tool. It's not definitive. Use it as part of your assessment, not make it your assessment. The measures, correct, don't rock. So it's like this. You come in, I'll show you guys. I'm going to demonstrate on somebody in the room who wants to be palpated. In and then come down. Okay. We're going to measure the patient's oxygen saturation of hemoglobin in the capillary beds. Okay. Patients with difficulty breathing should receive oxygen regardless of pulse oximetry value. They say they're short of breath, give them oxygen. Capnography can quickly provide information on a patient's ventilation, circulation, and metabolism, non-oxygen saturation. Capnography is done with a waveform. It is measured through a number and a waveform through nasal or mainstream. All right, there's different devices hooked into cardiac monitors. You can actually see it. I'll take one out and show you guys today for the nasal. Capnography is absolutely phenomenal. It will tell you when a patient is apneic within seconds. A person can stop breathing, and still have a pulse ox of 100%. Because it takes minutes to start registering that there's no oxygen coming in. Versus capnography, which is 10-second, almost instantaneous. When it tells you you're not breathing anymore. Because it is measuring your carbon dioxide levels, not oxygen levels. So it knows when you stop breathing. We can try that today if someone wants to hold their breath longer. All right, blood glucometry, blood glucose. Measures the amount of glucose in the bloodstream. Clean the finger, wait for it to dry, don't blow on it, don't touch it, right? You stick the lancet, it pops, throw it in the sharps container, squeeze the blood out, put it in the meter, give a reading. Huh? Good luck getting it out of someone who has poor circulation. You're gonna have to squeeze the blood out. But if you do, 4 fingers, 2 fingers, 2 thumbs, and squeeze. Don't touch the top of it. If you touch the blood, then you contaminate it. And if you had any kind of sugar on there, it's gonna read, right? It says not to squeeze it. I'm telling you, it's real world stuff. You gotta squeeze it. It's not gonna come out. Pediatrics, heel sticks on the heel. All right, blood pressure. We covered that already. Yep, so right here on the side. Yeah, I always go to the side here, and then I give it a squeeze like that. All right, reassessment. Perform at regular intervals during the assessment process, every 15 minutes for stable, every 5 for unstable patients. Repeat the primary assessment, repeat vital signs, and look for any kind of trends. You want to document your trends, right? If the blood pressure is going up, then we're going to document that. If it's going down, we're going to document that. We're going to reassess the chief complaint. Remember, patients can get better in your care. That's our whole goal behind it, right? So reassess it. One complaint may have gotten better, and something else may have gotten worse. You got to ask them. You still transport, especially if you've done interventions. If you've given nebulizers and things like that, then you need to transport them. Because the medications we're giving can also cause heart rate increases as well based on the sympathetic effects, the beta 1, beta 2 effects of medications we're giving like albuterol. We're going to recheck interventions. Most important are the patient's ABCs. So if you're continuously having a conversation with them, it's fine. We're going to ensure management of bleeding. Make sure that if the tourniquet's working, it's still working. Once it's applied, please do not take it off to check and see. Leave it on the patient. And ensure adequacy of other interventions as well. And last one here before we go to review. Identify and treat the changes in the patient condition. Document any changes, whether they're positive or negative. Patient gets worse for something that you did, you have to put that down. Unstable patients every 5, stable every 15. All right, let's do some review questions, and we'll do some practical stuff and get out of here. So during the scene size up, you should routinely determine all the following except. Got B's? All right, no one's gonna hide behind text today. Yeah, the answer is B. Good job. Number 2, you arrive on the scene of an injured person. As you exit the ambulance to see a man lying on the front porch of his house. He appears to have been shot in the head and is lying in a pool of blood. Yeah. Do you feel safe with someone having a gun there? Right? So the answer is D. You need to protect yourself. Because what if someone shot him and is around the corner waiting for you to show up? PD needs to get on scene first. I had a guy that shot his hand off. He was cleaning his gun in his house. And he had a kid in the residence, in the living room. He was in the open concept kitchen. He was cleaning and blew off his hand right here, point blank. We staged for 45 minutes waiting for PD to show up. We couldn't go in because he had a gun. We were told to stage. So we waited 45 minutes. He was getting upset that we weren't there yet. And it took PD 45 minutes to get there. So, couldn't find us. We were parked at the end of the road waiting. When you stage, you don't stage near the driver, the residents at all. Findings such as inadequate breathing or altered level of consciousness should be identified in the right. Awesome. A it is. Which of the following would you not detect while determining your initial general impression of a patient? General impression. You guys agree? D? Yep. The heart rate, even the feeling. That's what you walk in and you see first thing. Your primary assessment of an elderly woman who fell reveals an altered level of consciousness and a large hematoma to her forehead. After protecting her spine, you administer O2. You should do what? Yep. Rapid assessment. I heard you say it. Yeah, rapid assessment first before we get into our detailed stuff or secondary. Now, you can do a detailed on scene depending on status of patient, things like that. But with her, elderly, fell, hematoma, head injury, you gotta get moving. Yep. Semi-conscious patient pushes your hand away when you pinch his earlobe. You should describe his level of consciousness as. All right. Assessment of an unconscious patient breathing begins by right. So if the patient's unconscious, the first thing you're going to do is what? Where does it begin at? They're unconscious. Before you get to that, you have to do what? You have to open it, right? How do we open the airway? Louder. You got to position the head. This is a national question that you would see. Position the head first before you put an airway in. Because the airway may be obstructed just because his hair is like this versus opening it back up. Yes. Was that? Yeah. Begins at. These are the questions you're going to see in your national exam. Pick out the keywords. Yep. Your 12-year-old patient can speak only 2 to 3 words without pausing to take a breath. He has a serious breathing problem known as. Don't read into it. B. Number 9. How should you determine the pulse in an unresponsive 8-year-old? Was that D? Unresponsive. First thing you check. Carotid pulse. Right. Looks like you're trying to choke them out. Unless they're less than 1 year, you should palpate the carotid pulse of the neck. If they're less than a year old, we're checking brachial. All right, number 10. When assessing your patient's pain, he says it started in his chest but has spread to his legs. This would be an example of what part of OPQRST?